this podcast is about benzos, and the reason that we're doing it is because they're everywhere, right?
Yeah.
They're everywhere, and I think it's a really poorly understood sedative as to like what the use cases for it are, where it fits into addiction, psychiatry, and neurology. And there's quite a few cases of overdoses, right? I think about 10,000 per year that are occurring for this, and it's not really clear as to what the proper use for it is because it doesn't fit into the FDA guidelines for like how it's being used today.
Really?
So we'll get into that too, right? Because there's some really interesting statistics about that in terms of what it's clinically approved for and what they're actually using it for today.
Really?
And so it's an interesting lens in terms of like how we're using pharmacology to offer relief for patients, but
Mm-hmm.
in reality, it may be causing more harm than it is good,
Mm-hmm.
especially with how they're using it today. Um, and so I guess what we're going to do is we're going to talk about like the history,
Okay.
the pharmacology, just talk about some of the different benzos that are out there, go into epidemiology, the misuse of it, a deep dive into dependence, withdrawal. Like, I mean, I'm an addiction medicine doctor, right? You've got a treatment facility, and
Mm-hmm.
so we're going to look into that, the proper ways to withdraw from it, and then policies and controversies around all of that, right? How we're prescribing it and what the actual like use for it is.
Okay.
So,
So, okay. So, what problem were benzos originally solving?
okay, so back in the day, right before we had benzodiazepines, we were
Mm-hmm.
using barbiturates.
Yeah.
And barbiturates were one of those things where if you mixed it with another sedative like alcohol, right, people were dying off of it. And so
Yeah.
there were all these deaths from people mixing their barbiturates, like phenobarbital and all of those things, with alcohol. And so because of all these deaths that were going on, right, they were like, well, wait a minute, we need something that we can still use for anxiety, but this isn't going to kill the people that we're treating it with. And so they came up with this with the benzos, right? And they found that the benzos worked differently on the GABA A receptor than it did the barbiturates, and
Mm-hmm.
we'll get into that also. But it's become a huge market, and it's growing and growing and growing, and it's like the modern day tranquilizer, right? And the demand has just gone through the roof. Just the number of people that are using it today
Yeah.
has just gone up and up and up. And I mean, if you looked at it, it's been around for a while, right? I mean,
No,
it's
yeah,
it's been around for quite a bit of time, and it's got a very interesting sordid history to it.
I bet.
Yeah.
Okay, so how did benzos first emerge historically?
So they were brought up in the 50s,
Okay.
right? When they first developed Librium,
Okay.
which is the oldest one, right? We use Librium today for alcohol withdrawal.
So Librium's a benzo.
Yeah, Librium's a benzo.
Okay.
Chlorodiazepoxide.
Okay.
And it's a long-acting benzo. It was first originated in the 1960s. Then they developed Valium,
Mm-hmm.
and then because the Valium was like shorter acting and it gave you more of a buzz, like
Mm-hmm.
it became the popular one. And so then the other one was like, oh, like people didn't like the
Long.
Librium as
Yeah.
much as they liked the Valium. And
Yeah.
so when they came up with the Valium, they were like, oh, like people really like these, right? So we're going to use more of these.
Mm-hmm.
And so they were marketed as safe, non-addictive, right? As they always do, right?
Par for the course.
All of the drugs of abuse today, right? When they were first introduced into the market space, it was all totally
Safe. And
safe, not a problem. You can use it without any dependency. It's the perfect adjunct. Like it's not going to kill you like the barbiturates did, and so it's totally safe to do.
do you remember the North Hollywood shootout, the bank robbery?
Yeah, you told me about that.
Dude,
And
they
those
were on
guys,
they were on so much barbiturates.
barbiturates or benzos?
Barbiturates.
Okay, and they were
It
just
it slowed their heart rate down.
uh-huh.
They didn't like feel any pain. It was yeah, they were like
How are they
drinking.
functional though?
I don't know. Well, think about all the adrenaline.
Right. Oh, that's running through as you're getting shot
Yeah.
up. Yeah.
Yeah, yeah. So,
That was a seminal
oh,
like when I was growing up, because it was probably I think it was like during the summertime, and we're sitting there like like
watching
watching
TV.
TV,
Yeah.
watching cartoons, and all of a sudden it comes on, and you're just like, what is this? What's going on?
That is one of the only bank robberies and like shootouts that were actually caught from the beginning all the way to the end on TV.
Okay, interesting.
Hmm.
They didn't because they didn't get off of it, or they just stayed on it the whole time.
Well, the way that it ended up getting picked up was a cop drove by while one of them was like looking out while they were in the middle of the robbery,
Okay.
and so that cop at the time there was a bank getting robbed every 17 minutes in LA County,
Mm-hmm.
and so they were already like on high alert. They saw this guy with full body armor, mask, and a fully automatic weapon.
Right.
Called all these cops there. The news was there, and so by the time they came out, everybody was already there,
Interesting.
and they just came out guns a blazing.
Yeah.
But they were on so much barbiturates, they it could have killed a horse.
Yeah, they just didn't feel any of it.
Yeah,
Yeah, I can see how that's beneficial, right?
yeah,
But so the benzos were not for the shootouts, right? The benzos are
right,
more of like mommy's little helper, right?
right,
That's what you
right,
got in
right.
the 60s and all those advertisements around that. In like the 70s and the 80s, it started being used for anxiety, insomnia for people that couldn't sleep, and like muscle disorders, especially for people that had dystonias or like they had like achy muscles, and as something that could help relax things. Later on in the 90s, it started getting prescribed as an antidepressant, and then prescribed it with the opiates, right? To be like, oh, like if you know, if you're on
Mm-hmm.
opiates, just mix in a little bit of benzos, right? That'll help out too. In the 2000s, they became chronically used despite the short term labeling for it, right? So we can start talking about that. So the FDA um, states that a benzo is safe for, I think, about 6 weeks. And that's like the maximum duration of time that it's like okay to
No
use it.
way.
Yeah. So it's 6 weeks. And nobody complies with that. Everyone just goes, use it for as long as you want to, right? Because as a doctor, you don't have to follow those guidelines if you can justify it like it's we're using it for this. But initially, only justified for 6 weeks, maybe eight. It's a short enough duration that what it's being used for today is just absurd. That's what the FDA recommendations are.
I know somebody. I know somebody that he's been on Adderall and Valium for 20. Okay, I was 12. I'm 30, so 24 years.
That blows my mind. I had a patient come into my clinic and I was like, "What are they prescribing here?" They're like, Adderall and Vyvanse in the morning, and I was like, "Wait, what?"
Both.
So the thing is that so he's like, so the Adderall, so the Vyvanse was for the long acting, so there's a
Yeah.
baseline to it, and then he was like, I can add on Adderall here and there if I need it, and I was like,
Oh, if I needed
okay,
it.
he's like, when do you not need it, right? And he's like, well, that's interesting, right? I just take it, 2 or 3 times a day, and I'm like, okay. And then I'm like, so what's the clonazepam for? They're like, oh, when I can't sleep at night, that's what I take. And I was like, I would look at him and I was like, you were on the Elvis Presley diet. You got a stimulant in the morning and a depressant at bedtime, right? And I'm like, what are they treating you for? And he's like, bipolar. And I was like,
Oh my
what?
gosh.
It just didn't make any sense to me whatsoever, right?
Check this out. The
But I've been
taper queen just said that Xanax isn't supposed to be taken for more than 2 weeks.
2 weeks.
2 weeks.
Who's that? The taper
The
queen?
taper queen. I've never met her.
Okay,
I don't
awesome.
know.
How exciting.
Thank you for that little nugget. Two
Yeah,
weeks.
2 weeks. So that's insane, right? Because people stay on that forever. And then you wonder why the dependency starts just going up and up and up and up.
Oh,
And
dude.
people that are on it for like
Have you
20
ever
years.
taken benzos?
I think the only time I took it was so. So when I went to my first exposure to a benzo was when I was in medical school and we went down to Cancun for spring break,
Oh yeah, it's
and
everywhere.
the guy was like trying to sell me benzos, right? And I was like, "No, man, like I don't want any benzos. Can we get some Adderall?" And he's like, "No, we don't sell Adderall here. We just have benzos, right?" And I was like, "Why would I want to take a benzo when I got all this alcohol for free, right? Like why would I want to mix those two?" And so that none of that made sense to me. But the people that I'd gone with were all of these like high school kids because it was the parents of a guy that I went to medical school with, and he brought his brother and like his entire family from New York. These are like these Italian guys from where were they
Jeez.
from? They were from Staten Island.
Oh
All
boy.
right, so it was just insanity that was going on there. The only time I think I've ever taken a benzo is when I was detoxing and I was going into the psych facility.
And they prescribed it to
They
you.
prescribed it to me because I was like trying to come off of it.
So the taper queen. I'm assuming that the taper queen has that name has something to do with tapering off of
Okay.
drugs or
No,
something.
that's interesting
Yeah.
because maybe that's one of the groups that you sent it to.
Well, she said that she's been through benzo withdrawal. It's awful, worse than opiates,
Yep.
and the reason why a lot of people get protracted withdrawal. Are we gonna go over this?
Yeah, we're gonna go over this.
Okay, okay.
Yeah.
Getting ahead of us,
Well,
getting ahead of the
what does
skis.
she want to talk about?
She said that that is the reason why they have protracted withdrawals because well, first of all, the 2 week period,
Yeah, that's
people are
absurd.
blowing that out of the water. Years that they get this
Yeah,
prescribed for
yeah,
years.
yeah, and you become dependent upon it, right?
Yeah.
And so it's really tough. So I'll get into that. I'll get into
Okay.
that in like about like half an hour or so,
Okay.
as to what the prescribed methodology for tapering it off of it is, and like what actually happens,
Okay.
right? Because it's insane, and
I bet.
there's a reason why people never get off of it because it's so hard to do. Um, but so okay, so then in and around the 2010s, right, the intention shifted because they started seeing like how people were becoming dependent upon it and all the harm that it was causing.
Yeah.
So you start looking at like the opioid stuff's coming along, and like they're like, oh, well, there's this opiate epidemic, right? But the unknown one was like the benzodiazepine epidemic, and
Hmm.
so they started being more cautious of how they were prescribing the benzos along with the opiates. So they kind of like went hand in hand together.
The addiction also goes hand in hand as well.
Oh, really?
Yeah, I don't really know why because my experience with benzos is it doesn't matter how little I take, I black out almost immediately.
So my from what I talked to about patients, because that's not my story. My story was never
Right.
opiates or benzos. It was always alcohol. But the story that I get from them is that they're taking the opiate, they're taking the benzos as a way to come off of the opiates. No,
Nobody's coming off the opiates.
like when they don't have any.
Oh,
Like in
okay.
that, like when they're in their withdrawal period, right? They're like, oh, I need like I can't get the opiates right now, but I've got these benzos, and so I'm just gonna take them.
Yeah. So what I always heard, because like I said, I have taken a lot of benzos, but it was always like to time travel. Like I would take one and I would wake up 3 days later, right? Even though I was fully functioning the whole time.
That's all blackout stuff, right?
All blackout stuff.
Yeah,
But what most people take it for is because it makes you more sensitive to the opiate.
because it makes you more sensitive.
Like
Okay, I
it
can
is
see
a
that.
much more euphoric high.
Okay, I can see that. Okay. And so benzodiazepines, right? So like
Hmm.
the way that they work inside the brain is that they work on the GABA A receptor,
Okay.
and it basically it causes an increase in the chloride influx, and the neuron right becomes hyperpolarized, and then it has decreased excitability in the limbic circuit.
Okay.
So just flooding the system with a whole bunch of GABA,
Hmm.
because GABA is the there's like glutamate, which is like the excitatory, and then GABA, which is the depressant side of it, right? The inhibitory neurotransmitter. And because of the rapid effect that it has in the amygdala, it causes like your fear to go down, your anxiety to go down, and you get this like sedative, like anti-anxiety feeling that comes from it, and it's also really good anticonvulsant because of those particular
Right,
properties.
right, right.
Um,
So what differentiates one benzo from another?
okay, so there are so many different benzos out there;
Yeah.
it's ridiculous. I mean, I remember when I was going through medical school and like we were like listing them off. I was like, "What? There's like there's like 40 of them.
Hmm.
There's just so many of them. Most of them like you'll never hear about because they're not FDA approved or they're not sold commercially. But they all have like different properties, and the different properties. One of the characteristic ones is how quickly can it get into the brain, like across the blood-brain barrier,
Okay.
and so how lipophilic is it? The other one is like how long of a duration does it have
Hmm.
in terms of like what's the half life of it, what's its like active metabolite, what does how long does it stay along inside of the system, right? And then are there any prolonged pharmacological effects from it because it metabolizes differently in different parts of the body? Are there formulations oral, IV, intranasal, or IM? Right. And so all of those things matter in terms of how you're trying to get the benzo into the system. And there's
Hmm.
different clinical uses for each one of those.
Yeah.
Um, and so,
So okay. So why does half life matter clinically then?
so, I mean, it's all about the duration and the brisk onset and the offset.
Okay.
So the longer the half life, the smoother and the longer coverage it has. The shorter the half life, the lower the dosing is.
Yeah, yeah.
What are you doing?
Okay, so what I would always assumed was the shorter the half life, the faster you get high on it.
That I would equate it to the I want to say that that may or may not be the case because there's certain ones like midazolam that are only used for like surgeries and like rapid
Hmm.
induction. when you're trying to like knock somebody out for a surgery or for like some type of procedure. So I mean that's super short acting. I don't know if people get high off of that or if anyone would ever use it to get high.
Yeah, I think that would be so
So quick that
quick that it wouldn't. Yeah,
it wouldn't be worthwhile, right?
but like when you look at Xanax versus Valium,
Yeah, the
right?
Xanax is definitely the shorter acting one,
For sure.
and it hits you harder and it
Mm-hmm.
stays for a shorter duration. I think for me, it's like the addictive potential is how dopaminergic is something.
Oh, for sure.
Like how much dopamine is being released and how much is my brain being tricked into like, oh, like this is something that you really really want. Um, the different durations and the different like onsets kind of lead to different strategies for coming off of them and different strategies for like what they're actually being used for.
Yeah.
Yeah.
Okay, so how are benzodiazepines typically classified by duration?
So there's four categories that we have for them, right?
Okay.
So there's the ultra short acting,
Okay.
which the half life is under 6 hours. There's the short acting, right, which is anywhere between 1 to 12 hours. There's the intermediate acting, which is 12 to 40 hours, and then there's super long acting, which is anything over 40 hours.
What are the 40-hour ones?
So we'll get into that,
Okay.
right? So the let's go for the super
Okay.
short ones, right? So the super short one is midazolam, right? That's the one that we use for like procedures or like if they're going into surgery, or if you're like you're getting a colonoscopy, like those are the ones that you use for that,
Okay.
basically to knock somebody out. Triazolam, we use that for insomnia. It's a shorter acting one, but it's really good for like inducing sleep and like knocking people out. Oxazepam is another relatively short acting one. I use that one in the inside of the detox facility if I can't put you on phenobarbital or you've got liver issues because the oxazepam doesn't get metabolized in the liver. It gets metabolized in the kidneys.
Okay.
But it's also a short acting one. And then temazepam, we also use that for sleep. And then so then there's the intermediate
Yeah,
acting
yeah.
ones, right? So the intermediate acting ones are the alprazolam. It's rapidly inducing, but it also like lasts for a while. And that one has probably the
Up.
highest possibility of misuse.
Right, and that's Xanax.
That's Xanax,
Okay.
yeah. Then we got lorazepam, which is Ativan,
Mm-hmm.
which is kind of like the intermediate one. That's the workhorse that we have for detox.
Yeah, I think it's also one of the least euphoric ones.
Okay.
Um, you know,
And so that goes back into the dopamine side of it, right?
mm-hmm.
Like how dopaminergic is something because it's really effective. And so we
Oh
use
yeah,
that one for people that are convulsing or having seizures. We put it with like 2 or 3 milligrams into their body, and then they're calm and they're
yeah.
quiet afterwards. You can do it oral. There's IM uses for that. Then we got clonazepam, which is a longer acting one,
Mm-hmm.
but it's still underneath it's like considered intermediate, but it's the longer of the Ativan versus the Valium versus the Xanax. And so there's a bunch in like in Europe also, but the ones that I mentioned are the ones that you'll see most commonly here in the U.S.
Mm-hmm.
And then there's the ultra long acting ones, right? So diazepam
Mm-hmm.
has a fast onset, but it has a really, really, really long like half life. So you can use that as something that you can rapidly induce, but then it also like stays in the system for a while. So if I'm doing like a long taper, I'll sometimes use diazepam. You've got Librium, which is like the workhorse of the detox stuff, especially in an outpatient setting. The reason that we give patients Librium in an outpatient setting is because even if they drink on it, they're not going to die, right? So one of the things that you watch out for is if I've got somebody that's in the hospital for alcohol withdrawal and I want to discharge them, I don't want to give them something that they can potentially abuse and like die off of.
Yeah.
So I give them Librium, which is a long acting one. So even if they drink on it, it's like not the end of the world. They're not gonna die off of that one.
I mean, so growing up, there was a mom. It was so funny. She would sit in her bed, like when she was going through it, she would just lock herself in a room and watch I Love Lucy.
What do you mean going through what?
So I don't know exactly what was. She was very obviously bipolar, but there was some other stuff going on, and her son would steal her medication, and
Okay.
so once a month, like towards the end of the month, she would just be in her room watching I Love Lucy for days, and all she would really have left was her Librium, right?
Okay.
Because he would take the benzos and the Adderall,
Okay.
and so like we
Wait,
always
she was
knew.
bipolar and she was on the
Hmm.
Elvis Presley
I'm
mix too.
pretty sure she was bipolar. I don't know what the
Okay.
actual. I was so young, I was like 14 when we became friends,
Okay.
and all I knew was that like she was fucked up, and then as time went on, I realized like, oh, my friend's stealing her medication. That's why she gets fucked up at the end of the month.
Got it. Got
Yeah.
it. Because she doesn't have anything to like keep her like
Hmm.
sedated
Other
or
than
like
her
high.
Librium, and she would talk about like, will you bring me my Librium? Like,
That's all that's left.
yeah.
That's funny. Um,
Hey, so the Taper Queen asked, can you go over some of the ones that haven't been FDA approved, like Floralprazolam?
Flurazepam.
Yeah,
Okay. Uh,
and clonazepam, loam,
ooh, I don't know.
clonazloam.
I don't know that one.
Okay,
Clonazepam. I don't know that one. I know the flurazepam.
it's
Is
it's
it
FLUALPRA,
F?
flurazepam. Why do they name them such crazy names?
I don't know.
Okay,
That I don't know. Is it this one up here?
no,
Okay. I don't. I'm so sorry. I don't know all of them
yeah. Well,
because
these
there's
are the
so.
non-FDA approved ones. She's asking.
So what I do know is that there was at some point in time when what was happening was they were making them more and more potent and more short acting and higher like potency.
Yeah,
And at some point, the FDA was like, wait a minute, this is ridiculous.
yeah,
Like, can we just stop doing this? Like, there's no reason to have a drug that does this.
yeah.
There's no medical benefit from it. There's no reason why you should be flooding the market with this. So they basically like started banning them. And
Okay.
they're like, well, you can't do that anymore. And so like the one that they left, I think the short acting one was like Xanax. Xanax was like the short one, but they had the capacity to build more, or they were developing more and more that were shorter and more intense, and they or their potency was a lot higher. The FDA was like, you need to stop.
Yeah, because I mean, Xanax is already so crazy,
Right.
right? Like the
And
if you have anxiety, it takes the anxiety away, but it's
right.
like it goes beyond fixing flual flualprazolam.
Flu alprazolam. I don't know. So was that one? So was that one denied or
Have you ever heard of etizolam?
I haven't heard of that one either.
Oh, she said it was a nasty research chemical.
So that means so that's what they were doing, right?
Yeah,
They were going to the point where uh
you're good.
they were going to the point where we they there was no medical use for it
Yeah,
other than getting someone completely hooked on a drug that like that would keep them dependent for a while.
yeah.
And so the FDA was like they like nixed that. They were like there's no reason to do this.
So are they still allowed to do the research, but they're just never allowed to kind of like bring them forward as like to
I think they're still out there. It's just you can't bring them to market.
yeah,
So like it'll be there for experimental use or for whatever.
research?
Yeah, but there's no clinical reason to have that.
Okay.
Yeah. So basically like we were saying before, right? The faster the onset, there's general like increased reinforcement and the rapid hit links to euphoric risk. Right? So the ones that she's describing had higher, faster onset, right? And then it had a more euphoric hit to it,
She's
making
saying
them
that that one
being
is
more dependent.
that it's legal in the UK.
Okay.
I wonder. Yeah, it's crazy.
Yeah.
Hey, everybody that's in here, if you haven't subscribed, please subscribe.
Yeah.
Okay.
So but the reason why the longer acting ones were being used is because they had a much smoother like onset, and it was a much subtler feeling, but it's still really I guess insidious, right? In terms of like how the dependency forms
Oh
on
yeah.
it. And so what was happening around probably like the 2000s and the 2010s is that they were switching off of the diazepams
Hmm.
and the Xanaxes, right? And then all the psychiatrists were like, okay, we can't give you those anymore because those are like really addictive, right? So what we're gonna
Hmm.
do is we're gonna put you on clonazepam, right? And they would just start going up on the clonazepam, but it was like it's the exact same thing, and the
Yeah.
exact same dependency occurred on it, and they got to a point where they just weren't able to come off of it. It became so difficult to come off it, and we'll talk about that in a second.
Yeah. The dangers of coming off of it, or just the difficulty of coming off, or both.
I think once you get up to a certain dose, because the way that it worked, right, is that as soon as you'd start them off on 0.5 milligrams of clonazepam like twice a day, right, and then if they came back in and they started having breakthrough, right, the anxiety, you'd be like, oh, like no problem, we can totally fix that, right? Like let's go up to 1 milligram, right? Then it would go up to like 1.5 milligrams, And the crazy part is that they were they weren't having more anxiety, they were having withdrawal.
Yeah.
They started
Oh.
their body started getting accustomed to like that amount of it, and so
Yeah.
eventually they were in a perpetual state of withdrawal from
Yeah.
the medication, so that every couple of hours, like if they didn't take it, if they didn't increase the dose, they'd be in withdrawal. So you go like projected down to 3 or 4 years into the future, and all of a sudden you're on this dependency, right? And you're on like 2 milligrams or 3 milligrams of it a day, and you can't come off of it because at the moment you start coming off of it, you feel absolutely horrible.
Yeah. Does it do like structural changing to the brain at all?
Yeah, in terms of
Okay.
like the dependency and like how your brain acclimates to that amount of GABA inside of the system.
Okay.
It's the same as like being an alcoholic, right?
Yeah.
We consider the benzos alcohol in a pill format, right?
Yeah.
So in my clinic, we don't prescribe those. There's zero reason for someone. I mean, okay, not zero. There's very little reason for someone who is an alcoholic or an addict to be on any type of benzo, just
Yeah.
because of the risk is so high that there's other ways of like helping to treat whatever's coming up than giving them a benzo.
Okay.
Yeah, I mean, so but there are legitimate reasons for it, right?
Okay.
And it's for acute anxiety, panic attack, crises. Um, from a neurological perspective, right? It's status epilepticus, which is basically seizures that don't stop.
Hmm.
The benzos are an excellent way of like treating that and shutting that down.
But does it also cause it?
Yeah, if you're
Yeah. Yeah.
withdrawing
Yeah.
from it, right?
Hmm.
Like people go into status epilepticus all the time because they are coming off of the benzos and they came off of it too fast or they got into like some issue with it. Um,
So then the cause is also the cure.
yeah, but I mean, if you've got a seizure disorder
Hmm.
and you're on like Keppra or you're on Topamax or you're on Lamictal or some type of anti-seizure medication and you have a breakthrough seizure or you didn't take your anti-seizure medications for a while and you come into the hospital and you're in status, they give you a whole bunch of benzos to shut it down because it's
Hmm.
really effective at that, just quieting the brain down completely.
Okay.
Um, we use it for peri-procedural sedation, anesthesia adjuncts, and then as an addiction medicine doctor, right, I'm using it for withdrawal and other sorts of ways of treating withdrawal.
So when I came into you for detox, what was? Oh, it wasn't
I
benzos. It
wasn't
was
using a benzo. I
right,
was
right,
using
right,
phenobarbital.
right, right.
You're the one that brought in the benzos.
Yeah, yeah. Uh, so I ended up peeing for barbiturates for like a month and a half.
Yeah, I think you told me that.
Yeah.
And that's one of the things that we do in terms of coming off of the benzos, which I can talk about, right?
Hmm.
Which I think is a way more effective and compassionate way of coming off it, but it's not. They won't approve it. So that's an interesting thing that we can like talk about.
Okay.
Because I had this idea for, I had a patient who came into the diagnostic a while ago, and she was stuck on she was getting Adderall and clonazepam at bedtime, right? And I would tell her, you're on the Elvis Presley diet. Wouldn't you want to just come off of it and like let's just see what happens like when you're off of everything? And
Yeah.
she's like, well, how do I do that, right? And so we're like, I was like, I'll take you through a detox process, and we'll
Hmm.
detox you off of everything, and then we'll just see where you're at, and we'll send you to a whole bunch of like inpatient intensives to do your family of origin work and all of that stuff. And she's been great ever since. It's been like maybe 5 or 6 years.
So when you're detoxing and you're tapering down from such a small dose anyway, are you doing incremental lowering of the doses? And how does that work?
In terms of the coming
So,
off of it in an outpatient setting,
or any setting, right? Because
okay.
I mean, you're taking two
So
milligrams of
uh,
Xanax a day.
2 milligrams like isn't that much,
No, I
right?
know
Like in terms of like the overall thing, I think at 2 milligrams it's more of a psychological dependency than
for
it is
sure.
anything else. I think when we start looking at like 2 milligrams of clonazepam is when it starts to get like, oh, like this is really tough to come off of. So I
Okay.
mean, we can get into that now.
Okay.
So one of the ways, so the ways in which you come off of 2 milligrams of clonazepam is that your psychiatrist will be like, okay, we're gonna come off the clonazepam now, right? This is the way I want you to take it. I want you to go down by 0.5 milligrams every week for the next 4 weeks, right? So you'll come down, you'll go from 2 milligrams to 1.5 milligrams. For the next 4 days after you go down that particular dosing,
You're
It
withdrawing.
you're withdrawing, right?
Oh
So
wow.
you're in benzodiazepine withdrawal for like 4 days, right? Not to the point where like you're gonna seize or anything like that, but it's so uncomfortable. You have so much anxiety. There's like the perspirations. You can't sleep. The insomnia's in, and then your brain adjusts by like day four. So then, so day four, right? So let's say you started on Sunday, right? So you're miserable Sunday, Monday, Tuesday, Wednesday, right? Thursday rolls around and you're feeling like yourself again and you're feeling a little bit better. And then they're like, okay, great, let's go through that again for 4 days, right? And so every week for like 4 or 5 days, you're feeling absolutely miserable. You get back to a baseline and they're like, all right, let's do that again.
Wow.
Who actually gets through that and is like, okay, like I'm gonna be able to like do this?
Yeah.
I don't know. I know so many patients that are like really, really want to come off of it, but just can't do it because they can't get past like those particular periods of time.
So why wouldn't they elongate the taper process?
You still get those 4 days, right? So
Yeah.
what do you want to elongate it to, right? The way that you would elongate it is not by cutting down the you would elongate it by not doing the 2 to 1.5. You would do it 2 to 1.9,
7.5. Oh yeah.
right?
So this is what I'm asking.
1.8,
Yeah.
1.7. And I think that's what they were doing. And so there was a special on, I can't remember what it was, but it was like Lisa Ling. And I remember that because I went to college with her. And she did a special on benzos where like these people were tapering or self-tapering themselves down by mixing their own titrations and their own like concoction,
Yeah.
so they could like gradually come off it like in these like really really short increments, because they were finding that if they did it any faster than that, they would just they weren't able to tolerate it.
Mm-hmm.
um I've had patients that have come into clinic and they want to come off of it, and I tell them, all right, well, this is how we do it in an outpatient setting, and they're just like, there's no way.
Mm-hmm.
Like there's no way. And I'm like, all right, well, we can do it in an inpatient setting. So what I do in the inpatient setting is I put them on the phenobarbital, and I can get them off of the clonazepam in like 4 days or 5 days. And you leave them on Depakote for 2 weeks. You do a phenobarbital taper for 4 days or 5 days, and then you Depakote for 2 weeks, right?
This is such a.
The problem is that I've tried to get patients into behavioral health settings.
Mm-hmm.
I've tried to get them into like like someplace, and they're like, "Well, are you abusing it?" No, I'm taking it as prescribed. They're like,
Don't fit criteria.
"Okay, yeah, you don't fit criteria for this, right? Because you don't qualify for a drug and alcohol rehab
Mm-hmm.
facility." They're like, "Well, how do I come off of it?" They're like, "Well, are you
Work with your
abusing
P.
it?" Right? They're like, "Well, if you're not abusing it, then you don't need to come into our particular setting, right?" And some of them don't meet criteria, and so they don't really identify with it. And they're like, "I'm not going there with a bunch of like drug addicts and alcoholics and all that
Yeah.
stuff, right?" I'm like, just this mom who's like taking 2 milligrams of Xanax, but it can't, or 2 milligrams of clonazepam, and can't come off of it. And so the I'm convinced that there's a market out there for taking people off of benzos in
Oh
a
yeah.
controlled fashion, where you're like, all right, come into our facility, we'll charge you X amount of dollars, and we'll do it in like 6 days,
Okay.
right? And I think there's a huge market out there that wouldn't have necessarily be covered by insurance companies.
Mm-hmm. I mean, yeah, because you're not the well, self-reporting abuse is also really hard to depend on around this stuff because
Yeah.
the propensity for abuse around
Well,
them.
but it's also a lot of people don't want to get stuck with that label.
Oh, for sure.
Right?
Oh
You're
yeah.
like, but I'm taking it as prescribed. What are you talking
Yeah.
about? Right? Like, I don't have a problem with this. And then
Mm-hmm.
you go into rehab and you go into treatment. And they're like, you're an addict, and they're like, I'm really not.
Yeah.
Like, I started doing this, and I mean, would they benefit from a lot of the deeper work? Everyone would.
Of course.
Everyone can.
Of course. Were you ever in treatment with somebody who was not an addict?
I don't know if I would be able to tell that.
I mean, they were
Like,
saying like, I'm not an addict. I just have to, for whatever reason, I'm here.
while I was in treatment, or
Yeah.
like while I was a physician
Either
in.
way, have you ever seen those?
Yeah, like as a physician in
Yeah.
a treatment facility, like every other day, they're like, I don't belong here. I don't need to be here.
Okay. Did
I
you
don't have
ever
a problem.
did you ever meet one that truly wasn't?
I don't think you could tell in the acute setting. You'd have to find out like 4 or 5 years later, So I don't think that you have enough data points in the acute setting based upon what story that they're telling you
Yeah.
to be able to identify that. But you could tell in like 4 or 5 years down the road when you're like, maybe, maybe not, right?
Yeah.
Is your life better that you're not doing it? Oh, it is? Well, then keep having a better life.
For
Like,
sure. For
why would
sure.
you want to go back down that route? Um, and I know exactly where you're going with that, right? So, I mean, I hear you. Is it a possibility? Maybe, but like I said, you can't tell in the acute setting.
Yeah.
What are you gonna believe that person? You're like, hey, I'm not an alcoholic, right? That's like
Yeah.
literally everyone that comes into treatment.
So I
That
was
was
in
me coming into treatment. I don't have a problem. What are you talking about?
right.
I'm just depressed.
Yeah. I was with somebody that really wasn't an addict, and they ended up in treatment, and this was like that person that was like very compliant because of the consequences that
Yeah.
were over their head, right? But was like very, very adamant, like, I'm not an addict. I literally don't want to go to prison. And I was like,
Okay.
okay. And I watched this person and listened to like the stories, and like this person was very convincing that he was not an addict. And I
Okay.
was like, okay. So now I don't know if he
Are you talking yourself into it? Maybe I'm not an addict.
oh no. I am full blown. I mean, and nobody that's normal robs a bank because they were on PCP.
Well, I mean, okay. So I mean, when you look at my story, I was drinking every night
Yeah,
and was like suicidal, right? Could I have turned the boat around? Maybe, right? Could have gotten a lot worse? Definitely,
for sure.
right? So I'm like, might as well enjoy this life, right? It's way better than the life that it was before.
Yeah. Yeah, your stories are interesting to me.
What do you mean?
You just the way that cuz I don't drink. Like, and that does not sound fun.
I mean, I don't think the way that you did drugs sounded very fun either. I was like, so what do you do?
I think most people would agree that that sounds pretty fun.
What the way that you did drugs?
Yeah.
From what my image of people that do opiates, right, is that you get high and then you just sit there,
Yeah, I can understand why you think that.
right, and then you're just like, all right, what are you doing? Like you're not doing anything.
There were some there were some dens down in TJ where it was like really
That's
like
all they did.
I you would leave, come back like 2 days later, and the guy's still just like passed out in the same
Uh,
position.
that doesn't sound like fun. I mean, I could see like, I mean, I don't know. That's just war stories now. But
Yeah,
it was, it was socially. I was living in New Orleans, socially acceptable. Living in DC, living in LA, right? Like that's what
yeah,
people were doing.
that's
And then
crazy.
it just got to the dependency phase, right, where I couldn't not do it, and that was a really slippery slope.
Okay, so did we go over how benzos are used in neurology already?
Yeah, I mean, we kind of talked about that, right? In terms of like status epilepticus, in
Mm-hmm.
terms of the rapid induction to help out with epilepsy patients. It's really helpful as a bridge to when they want to start on, long acting anti seizure medications,
Mm-hmm.
like in case there's a breakthrough, in case something happens. They have that's where the intranasal stuff comes in. So like if you've got a kid who's seizing or a little kid, you can't really give them
Somebody,
anything in their mouth, right? So
yeah,
you give them intranasally.
somebody was just saying that they had no clue that you that they made them uh, for inhaling.
Yeah.
Yeah, who is
Well,
it?
that I
Somebody
mean,
right here.
so the reason for that, and the reason they use it for inhaling, is so that in case somebody is seizing,
Right.
and you're at home and you can't give them anything, right? The only way to get it into their system is either to do it intramuscularly,
Mm-hmm.
IV, or intranasally, right? You can also do it rectally.
Really? Well,
Yeah.
yeah, yeah, yeah.
So I mean,
Really?
if you yeah,
Because
they have support they have I think it's either Ativan or diazepam suppositories that you can give for like little kids. So like
okay,
these are
that
like
makes
so I mean
sense.
we did epilepsy clinic for a while,
Mm-hmm.
like during residency, and so you would see these kids that came in and sat us all the time, or like they had uncontrollable seizures, and all their parents could do was give them this when if and when they seized.
Have you seen all those studies that they've done around seizure? Oh, sure you have. Seizures and CBD.
Yeah, yeah, yeah. Well,
Crazy.
that's what we're gonna be talking about next week.
Yeah.
So there's only two or three FDA approved things for CBD, and one
Mm-hmm.
of them is for epilepsy, but it's a very specific type of epilepsy
Right.
that responds. I can't remember which one it was. It was like it's like early childhood onset this, right? And it's such a narrow category, but it's I mean it works super effectively for that. Um, yeah. And then we talked about how they're used in psychiatry for agitation, psychosis, mania, and then where they fit into addiction medicine, right? We use it
Benzos.
for
Where do benzos fit in? Yeah.
we use them for withdrawal. Sometimes we use it for stimulants when patients are like, if a patient comes in and they're still like high off of the stimulant, I will give them like a benzo to quiet them down so that they're not too bad on the come down side of it. And we also use it for GHB withdrawal. Um,
Really?
yeah.
That's interesting. I'm gonna have Robert come in here really quick.
Okay. There's Robert.
Robert Braun.
Okay.
But we can keep going.
Okay. And so
So, how common is benzo use in the U.S.?
okay, take a guess.
Uh, per capita?
So let's say our population is 300 million people in this
Okay.
country, right? What percentage do you think are on a benzo or have been on a benzo in the past year?
I would say somewhere around 30%, but I do know that there was triple the amount of prescriptions written that there are the amount of people in the United States, like annually. There's like almost 1 billion prescriptions for
Okay.
benzos written a year.
Well, that would make sense because then you would have to go like per year, right? Or
Yeah.
like per month,
Mm-hmm.
right? So each month is like so it's 10%. So there's about 30 million people in the past year have
Oh,
been
yeah.
on
That works out
benzos.
mathematically.
Mathematically, right? So so if you take one every month, right, you still got the 11th and 12th month to go.
That's crazy.
Yeah. So a lifetime exposure is around 12 to 13%. And the highest is in the middle aged adults, right?
That checks
Just
out.
taking it for anxiety. And they're like, oh, like I can't deal with work. I can't deal with this, right? Oh, just take one of these,
You know
right?
what's funny about that? I would venture to say that those statistics are dramatically off because they're talking about prescribed.
Prescribed, yeah.
Yeah. So
Well, how much? So, what about not prescribed, right? So,
oh, dude, it is.
come on, you have a skewed perspective on things. 'Cause, I
There.
mean,
Okay.
come on, you're living by the border in San Diego by Tijuana. Of course, you're gonna have issues with that, right? So
Yeah.
I
Yeah.
don't know.
Robert,
How's it going?
How you
Good to see
doing?
you.
You too?
come on over.
I'm over here. Good seeing you.
Good seeing you too.
Yeah.
How you doing?
We're just doing a
Good.
podcast.
Y'all are having a good conversation.
Yeah.
I had no idea you could inhale benzos.
Yeah.
I thought it was only, oral and then intravenous. Yeah. Oh,
I am
yeah.
too. And then rectally.
Hmm.
Yeah. They have special formulations specifically for intranasal.
That makes sense.
Yeah.
Where do you find out like an hour ago you were talking about, not that long, the dopaminergic levels of the benzos?
Yeah.
And certain ones have like a higher
And I don't know
engagement?
if they actually have studies on that. I mean,
Okay.
I'll look it up and I'll tell you the next time I see you.
Okay.
But the suspicion is like the dependency that forms on it.
Yeah.
If it's not based upon time of onset, it has to be based upon how euphoric do I feel off of this particular thing.
Right.
And the euphoria from most drugs comes from the dopamine release that comes from the drug itself.
That'd
Crazy.
be really interesting to know like which ones have the
Yeah.
highest amount. Definitely the onset. I've heard that with gambling. It's the repeatability,
Yeah.
the unpredictable results, and then
I love my
like,
slot
fast.
machines.
So,
Right? Just
yeah,
keep tapping away. Keep tapping away.
Dude, Texas is such a crazy place. There are slot machines everywhere.
Are there?
Yeah, there's a smoke shop across the street with taps in there.
Yep.
What? That can't be
Yeah.
legal. There's a smoke shop across the street with like
Well, I'm gonna show you.
that can't be
You go
legal.
in the
Yeah.
convenience store.
I literally got this earlier from there, and I was like, "Wait, what is that?" They're like, "Oh yeah, they're slot machines." I'm like, "What?"
Yeah.
That can't be legal.
It's store credit.
Oh, really?
The convenience stores will have them too. I
All
went
right.
into one to get a energy drink Thanksgiving morning. 4 people sitting in there like 7 o'clock Thanksgiving morning.
Store credit.
But yeah.
Oh wow.
So you're
That's
not
a
actually
crazy
getting-
loophole.
You're not
Yeah.
getting money back. You're
That is
getting
a-
store-
No, they get their cash, but
Oh,
that's
that's what
if
they
you
say.
ask, like if you walked in and you asked, they'd be like, "Well, no, it's just store credit." They
Okay.
just get a voucher for the
Yeah,
store.
it's like a little,
That's
it's
so
a little
funny.
game.
Yeah, exactly.
Customer retention.
So crazy.
Yeah.
It is.
Okay, let's get back to it.
Okay,
Okay.
I'll step out. Thank y'all.
Okay.
Good seeing you.
Okay.
Um. So okay. So the issue is that like Taper Girl, is that what her name is?
The Taper Queen.
The Taper Queen, right? So the issue is that they're prescribed long term, despite guidelines that basically say don't use it for longer than this much time.
Yeah.
And so people are on it for decades,
Hmm.
and they're like, I've just been on it forever, right? And they can't come off of it. It's it is a racket with less than ideal physicians, because they will get a patient onto it, and then like that patient comes in every single week, right? Every single week, here's $200, right? Here's $200, here's $200, and it's just they will never come off of it, and all of a sudden you've built up your entire practice on patients that are on Adderall and patients that are on benzo, and they're coming to you every single week, right?
Yeah.
And that visit is like, hey, you doing all right? Oh, everything good? Here's your urine cup. Okay, great. Oh, see you later.
Cha-ching,
Right? Then you're done.
cha-ching.
And then
Yeah.
how many of those can you have in like a day? You can have a ton of those in a day.
Yeah. I mean, I remember back in the day with the pill mills, there were people, I mean, we were little kids. We weren't like children, but we were like
Uh-huh.
teenagers. And I knew people that were flying to Florida and getting their prescriptions. And they would go from place to place to place to place, like just from one place to the next.
Okay.
And they'd do like this whole circuit. They'd go out there once a month and they'd come back with everything.
They would fly back.
It was their prescription.
Yeah, but you can't get like 50 prescriptions, or like you can't have like 800 pills or 900 pills with you.
Oh, they did.
Okay.
They
And they're
did.
like, all right, here's my prescriptions. Like all
Well,
900
here's the
of
thing:
them.
they're not getting caught with it. It's in their
Okay.
bag. They have the
Okay.
prescription for it. I mean, when you fly with stuff, they're
They're not
just
really
gonna,
searching you.
yeah. If especially if it's in a like, prescribed bottle with your name on it, like
Okay.
dude, my uncle would fly in California from San Diego to San Francisco, and he would fly with weed in his bag.
It's legal there now.
But it's illegal to fly with it. But
Oh,
they
really?
yeah, it's federally illegal.
Oh, okay. I did not know that.
But they just wouldn't mess with him.
Okay.
You know, like.
Interesting. Um,
Okay, so how common? So we talked about how common it is in the U.S., but
Right.
how common is the misuse?
I mean, that's really going to be tough to actually quantify.
Mm-hmm.
But like, let's just say for the general population, if it's like 15% of the population is addicted to something, right?
What?
It's usually 15. Like when you look at statistics for addiction,
Okay.
right? It's like 15%. 15% of the population is alcoholic, right?
Okay, that seems a little low.
That's the general statistic that they use,
Okay.
right? That's the number, right?
Okay.
So if we were to say 30 million people were using benzos, right? 15% of them were abusing it, right? So like maybe like
Okay.
4.5 million, right? But the statistic is 3.9.
That sounds so crazy.
Like you think that that's it?
Yeah.
Our perspective is skewed based upon the people that we hang out with and the population that we have, right? There are normal people out there that aren't doing drugs the way that you did drugs.
I know.
Right? There's like an entire world out there, right? Of like people that are normies,
Okay.
right? And
Okay.
I don't know who they are. I don't really interact with
Never
them.
met them, but they're out there somewhere.
I hear stories, right, of people that don't have these issues, and I'm
Okay.
like, I don't know who they are. I don't know where they are, right? But I hear that they exist.
Okay. Well, it sounds like there's a lot more of them than we think there are.
A
But
lot more of what? The normies?
yeah.
Yeah.
Okay,
Well,
but
so when we look at that, right, I believe that everyone. Okay, so two things, right? Nobody escapes their childhood unscathed,
for sure.
right? So there's some level of trauma with everybody, right? And everyone has their own particular escape hatch, right? It's just that like when we start looking at the people that are highly traumatized or like excessively traumatized, their particular escape hatch becomes something that is chemical that gives them immediate relief like right away, right? But other people that are less severely traumatized and they're like low grade trauma, low grade anxiety, right? They'll find other ways of compensating, right? Whether it be food, whether it be their work, whether it be like sex and porn and all that stuff. I think that it's the highly traumatized people that end up with the drugs and the alcohol.
So even with these statistics, I can what percentage of the United States is obese? We just went over this recently.
Yeah.
And I would venture to say that they should be lumped into a good percentage of those people should be lumped into these.
I
But
that's a slippery slope, right?
I know. So
Right?
I'm not expecting you to say anything. I'm just saying, in my opinion,
Right.
if you looked into what's really going on,
Yeah.
like it is a lot easier to overeat today than it probably has ever been with
Yeah, for sure.
all of these addictive foods and
I
then
was
terrible ingredients and all that.
I was watching a podcast where it says the food that we have out there in the market today is so poisonous that we developed drugs so that people wouldn't eat them.
Wait a minute. Did we watch the same? Was this in the same? Was this the neurology doctor? Was this the Dr. Amen?
No, that wasn't that one.
Okay.
No, it was like this was a lady and she was on some podcast, right? And I was like, "Oh, that's so profound."
Yeah.
Like the food out there is so poisonous.
We developed
Drugs so that we wouldn't eat poisonous food.
So we're talking about like GLP-1s. Is that what you're
yeah, the
talking about?
GLP
Okay.
ones and the stuff that's out there with that.
The taper queen, she asks if doctors are aware of how long they're supposed to be prescribed for and why are they over prescribing.
No. So I never learned that in medical school. I never learned what the
What?
guidelines for how long you're supposed to prescribe them for. I
Really?
never, and the thing is, I went through residency, right? Never got told how much that was. And so, like, there's some really interesting statistics out there in terms of who's prescribing what. And
Is
it
this one of
tur-
those 80-20 things where it's like 20% of the doctors are prescribing 80% of the medications?
Possibly, right? And I think what's happening is that there's a lot of non-psychiatric doctors
Oh,
out there
yeah.
that are prescribing the benzos
Mm-hmm.
without actually knowing, like what are the actual guidelines, right? Because they're just like, hey, you got anxiety? Well, we'll just do a short course of this. Oh, you're on this now, and so it's
That
it's a lot of it's a lo-
That brings up a really good point because when you go to a psychiatric doctor or
Yeah.
a psych anything, it's
Yeah.
really hard to get them to prescribe you benzos.
Yeah,
Right.
it's a process,
Yeah.
right? To like be like, no, well, let's try it. No, let's not. No, let's try.
Mhm.
Oh, like you're having panic attacks. Okay, like we're only gonna give you like, 10 days worth, right?
Yeah.
Or a script of 10, and that's it, right? And so they're really judicious about it. But then you go to like, family practice doctor,
Mhm.
right? And I'm not. I don't want to bash on them because it's not.
It's an education issue.
It's an education issue, and then it's like it's a how were they actually trained, right? And so like there's a study out there, and I read this article which I thought was really interesting, and it talked about how the majority of the antidepressants in this country are not written by psychiatrists,
Yeah.
right? They're written by family practice doctors,
Mhm.
right? So I wonder if that's the same scenario
Oh yeah.
with
sure
the
it is.
benzos, right? I'm pretty sure it's not the
Dude, I've tried to get them prescribed for psychological reasons. I've never succeeded.
you've tried to get it
Mhm.
like from a psychiatrist.
Mhm.
Okay. But
Yeah,
I mean,
never succeeded.
you go to your family practice doctor, right? And they're like, "Sure, what do you need? Like,
Yeah.
what's going on?" And it's unfortunately it's the economics of it, right? Like,
She said that her dad got Xanax for sleep
yeah,
from the
a
family doctor.
family doctor, right? Because it's like they don't know any better, right? And they want to help, and I don't think that there was enough awareness out there of those things, and so there's still older physicians that are prescribing that. Like today, you wouldn't get Xanax for sleep. Today, you'd get Ambien
Crazy.
or
too.
Lunesta, right? Which is as equally as disturbing in terms of the dependency that forms from those things,
Mhm.
right? But I mean, like they use clonazepam a lot of times for sleep now too, because the clonazepam was considered to be safer than the Xanax or the diazepam, and so like the family physicians or the people that were out there prescribing these things were like, oh, like we won't do that, we'll do this.
You know
I'm
what we
not
should
saying-
do?
I'm not saying everyone, right? But like, there's enough
For
of them
sure.
out there where like you kind of know who the person that's going to prescribe you what is going to be.
Mhm.
So
We should do an episode on sleep medications.
okay,
Because I remember the first time that I ever had formed like a chemical dependency was on Tylenol PM, and it was a mental thing, 100%.
you just couldn't sleep.
I just felt like if I took Tylenol PM, I could fall asleep.
Okay. I
and I
think
was like
that's
11.
like mainly Benadryl in there, right?
I don't even know what it is,
I think it's Benadryl or like some histamine in there that's causing you
which
to
is
be
funny
sedated.
because I've taken a bunch of Benadryl before and didn't feel shit.
Hmm. Yeah, I don't know what's in PM. So that's interesting, right? So okay, so 3.9 million. The
Yeah.
misuse is about 20%.
Mm,
20% of usage. I don't know. Like I'm telling you what the statistics are.
yeah,
You know,
yeah, yeah, yeah.
um, but you're like, no, it's gonna be higher. I mean, I think we are in a really skewed.
Okay, I'll give you an example. I know a guy, the guy that's been on the Adderall for breakfast and
Uh huh.
Valium for dinner
Okay.
thing. He normal guy, right?
Right.
But also
Functioning
will
member of society.
high functioning lawyer, like a
Yeah.
really really high functioning
Okay.
guy, but would
But you wouldn't call it abuse
if you're taking it not as prescribed, is it abuse?
if you're taking it not as prescribed. Is
Like
it
for
abuse?
maybe not for somebody who's not an addict or an alcoholic,
Right.
if you are taking it off prescription. So if you're taking it like two tonight because I got a appearance here and here and here,
Okay.
so
It
I'm
all
taking
depends.
two Adderalls in the morning
So
today.
so it all depends upon what your psychiatrist allowed you to do. So sometimes they'll like be like, okay, like here's your script for this.
Yeah,
But if you need it,
yeah.
here's a couple of extra.
Okay, so let's take that out of it though.
Okay.
If he just does it on his own, is that abuse?
It is a are there harmful consequences associated with it, or is he doing it
No,
like
no,
yeah? So
no.
then it's like it's I don't know. That's a tough one, right? Does he meet the DSM-4 criteria? No,
Fuck
he
no,
does not.
no.
Not even close, right? So like I think a lot of these are
Hey Terry.
do they meet criteria for abuse?
Yeah, no, they don't.
Yeah.
But for an addict or an alcoholic,
Oh yeah, for sure.
especially for somebody who's entered recovery or anything like that, if you're taking not as prescribed,
Not as prescribed. Yeah, that's an
we would
issue.
qualify. Yeah. Okay. Okay.
But that goes back to the to thine own self be true,
True.
right? Like I don't know. I can't be one to like tell you your sobriety.
Yeah, for sure.
Like that's between you and your sponsor.
Yeah.
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 Um. So where were we? Okay. So a lot of the misuse, right,
Mm-hmm.
comes from patients needing to get to sleep, or like abusing it for sleep because they couldn't fall asleep, or for whatever reason. Some of them are getting high off of it, and then some of them are misusing it for like cluster headaches,
Oh.
or like other mental health issues that are going on that they're not using it for. I mean, they're using it to come down because they're manic or whatever the other reason it is. Um, and
Okay.
so there's a population, right, that tend to misuse benzos,
Okay. So who
right?
is it?
Okay, so this goes back to the opioid patients and the stimulant patients,
Okay,
right?
for sure.
Like I know when I was taking Adderall during medical school, right? Like the alcohol was the way that I would fall asleep.
For sure.
So my use of alcohol went through the roof
Mm-hmm.
when I was taking like Adderall, right?
Of
Like I
course.
couldn't fall asleep.
Mm-hmm.
But if they'd given me some benzos, I would have been like, oh, okay, well this totally makes sense, right? Now I
Mm-hmm.
can fall asleep. Then I would have been addicted to two things, right?
Yeah.
Or like had
I mean, you
schizophrenia.
were.
Yeah, well, okay, yeah, the alcohol. And so the people with anxiety, insomnia, mood disorders, patients with individual prior use of substance use disorder or a polysubstance use history, right, are going to their doctors and being like, well, my doctor prescribed it. It should be okay, right?
Mm-hmm.
And this goes back to like if you're in recovery, going to someone who is aware of your condition is like not going to prescribe those things.
Yeah.
Like when patients come into my clinic, right? Like right off the bat, they know that I'm not going to prescribe anything that's controlled. Like the only controlled substance that I prescribe is Suboxone, and that's like on a limited number of cases. Like of my 300 patients, I probably have like 10 that are on Suboxone.
Okay.
Like not very many at all.
I don't fucking know. Zero said Xanax is the devil, right? Benzo withdrawal is the worst.
Yeah.
And he said he or she, I don't really know. That's kind of a ambiguous name. But when you first take it, it's beautiful. And when you get addicted,
It's
fucking
it's
terrible.
the idea that I'm in a constant state of withdrawal when I don't have it in my system. right? And so it's like you're in withdrawal almost every single day, and it feels miserable until you actually take it.
Yeah,
Yeah.
it's crazy.
And so overdoses, right? So we can start talking about that. There's
Okay.
I think in 2023 there was 10,870 benzo-related deaths that
Was it
involved benzos,
okay? Okay. Okay. That makes more
right?
sense.
But it wasn't just it was a benzo alone, right? It was
Right.
benzo and something else,
Opiates
like had
or
something.
alcohol.
Yeah. So like there's a hard, like I have a hard contradiction to taking like any benzo with any opiate, right? If
For
you're like
sure.
if you're in clinic and you're taking Suboxone and you're like test positive for benzos, it's like no go, right? And so it was about 16% of those were opiate deaths that involved benzos, right? So you're like depressing the respiratory drive even more,
Mm-hmm.
right? So it's the polysubstance overdoses are more likely than any signal overdose.
So, unless you're talking about opiates, but can benzos alone cause overdose?
It's really hard to do that. That's why they switched over.
Okay.
So it was really easy when we were
With
using the
barbiturates.
barbiturates.
Mm-hmm.
And so the need for the benzos became the fact that it was even more difficult to overdose from a benzo alone.
So, I don't fucking know. He's a dude,
Okay.
and he's a substance abuse counselor.
Awesome.
That is awesome. Thank you for coming. Please like and subscribe.
Like and subscribe.
Like and subscribe.
Okay.
Okay. So, okay, let's keep going.
Oh, sorry.
What are typical misuse patterns in clinical populations?
So it's, I mean, it's the insidious nature of it, right?
Mm-hmm.
So like, I mean, you've seen this, right? You're like, oh, like I accidentally took an extra one, right? Or like you
Mm-hmm.
just kind of like slowly creep up, and then all of a sudden it's the end of the month, and you're like, I don't have any left, right? Like,
Mm-hmm.
no one ever calls me and tells me that they ran like someone stole their propranolol from their car, or like it's always somebody took the Adderall, someone took the Xanax, somebody took like some controlled substance, right? So
You
it's
know what though?
insidiously like increase in that,
I feel like nobody would take their propanolol,
right?
even though if they understood what it was, I think they would steal it more often.
Uh,
But I know for me, when I was digging through people's medicine cabinets, I would have never understood what propanolol was, and I was looking for opiates and stimulants.
so you're basically saying that I should believe them when they're like it got
Some of them,
stolen.
I would assume that some of them are
Mm,
legit.
I have a policy in clinic of like I will believe you once,
That makes sense too, though.
right? And I track it.
Yeah.
And so it's not like I will forget. Like if you tell me, oh, I ran out of this, I ran out of that, right? Like you get like there's a little marker on the top of the EMR that's like on this particular date the patient stated this, right? And so like if it becomes the second time, I'd be like, I don't know, right? And the thing is, I used to be so gullible, right? This is like my people pleaser, like early on.
Uh
Like when I
huh.
firch started, they were like, I lost it again. And I was like, oh man, you're like the most unlucky guy
Oh
ever.
my gosh.
I had this one guy who kept telling me had like these elaborate stories around his Suboxone, and this was before I was like checking the PDMP like consistently and like religiously. Um, he was getting from multiple prescribers, and he was just telling this weird elaborate story of like I lost it like when I was going out of town for this or that, and I was just like I believed it. I fell for all of them.
Hey, I don't fucking know. Reach out to me on Instagram or Facebook, please. I want to talk to you.
Me or you?
I don't fucking know. Whatever his name is.
What, he wants me to reach out, or he
No,
wants
I
you to
want
reach?
him to reach out to me.
Oh, okay, okay,
He facilitates a smoking cessation class at his local Salvation Army, and
okay. Where's it located?
I'm trying to find all that out.
Okay,
I don't. He doesn't have to like put that on the. But I want to talk to him,
okay,
so we'll
cool.
figure all that out. The
Yeah.
taper queen, she's currently tapering off of methadone, propanolol, and clonidine. Oh, dude, clonidine. Okay,
Wait, methadone, propranolol, and clonidine.
yeah.
Okay. Are we going to be?
Oh wait, propanolol and clonidine are saving her. That makes total sense.
Okay, yeah, that does make sense.
Yeah,
Are we planning on taking methadone patients into the treatment facility?
that is going to be a you call for sure.
Okay.
Yeah, because we'll be set up clinic. I mean, we'll be set up for it. It's just how much work do you want to do in the detox?
it wouldn't be that hard, right? In terms of the detox itself, the
Mm-hmm.
question becomes, do you want them in general population as they're detoxing off of that? Because it wouldn't be a short taper. It would be like 10 milligrams every 3 days.
Okay.
And the only medication that I would use for that would be the clonazepam.
Mm-hmm.
The clonidine,
Clonidine.
the clonidine and the propranolol, right? As they were coming off of it, or as we were stepping down slowly. But that would be a long, protracted withdrawal, right? And then
Yeah.
would you want that person in general population with all the other people that were taking groups and stuff like
I
that?
mean, it depends on how the medication is dispensed.
It would just every morning, right? So
Because
like,
I relapsed in treatment on my roommate's methadone.
oh yeah, you don't give it to them, right?
No, he
You,
cheeked it. Like he cheeked it and gave it to me.
it's a
He was getting it in a pill,
Okay, no, we would give them
the
the
liquid.
liquid.
Mm-hmm.
Yeah, so the way that they dispense it here is the liquid, and then you would get like a 7 day supply of it. The reason why it's so difficult is that you have to find a methadone provider that works with your treatment facility
Mm-hmm.
to give them the 7 day supply, so that every 7 days you went and you got
Well, good
you
thing
picked
we
up the.
know. We know a couple clinics, right?
We do
Yeah.
methadone clinics.
Yeah.
Okay, well, I don't know any methadone.
Yeah. Yeah. Yeah.
Okay, well that
I
sounds
don't
good.
know. I don't know. Yeah, it's that one down in Pearland.
Which one?
We'll talk about it after.
Okay.
His name is Kent, and he lives in Fresno. Fresnex.
Okay, nice.
I have a friend. His last name is Scruggs from Fresno.
Right. So then the other pattern that we see, right,
Yeah.
is it goes from like, taking it as needed to taking it every day.
Mm-hmm.
So when like someone prescribes you like, take Xanax as needed, right? All of a sudden as needed is every day,
Mm-hmm.
every 6 hours,
Mm-hmm.
right? And then that's where the dependency forms, or you're combining it with some alcohol and you're like using it as the thing that gets you through your hangover.
So that's
So you're
another
waking
funny
up like
word.
shaky and stuff like that, and you're like,
Yeah.
oh, like I just take some Xanax and I'm fine.
Yeah. Yeah, that's another funny word that when it comes to medications is that as needed, right? That phrase.
PRN, yep.
Because I could justify
What,
anything.
there was a guy in the meetings that would be like, I'm the type of alcoholic that when it says, 4 milligrams every 6 hours, it turns into 6 milligrams every 4 hours, and that's okay by me, right? Like, yeah, like that's how it goes.
Yeah.
And then you got doctor shopping, right, which overlaps the prescriptions, and you're getting more and more and more of them.
So how do benzos interact with the opioid crisis?
So the coke prescribing around that time was a huge issue.
Yeah.
So when you would go into the
It was a
clinics,
2-for-1.
yeah. So
Yeah.
you would just go in there and be like, "What do you want?" And they're like, I want the somas, I want the benzos, and I
Yeah.
want the oxys." Right?
Mhm.
You would get all three of them at the same time, and then they were taking them at the same time. And there
Mhm.
was like the trifecta of like things that they would ask for. Remember when we were doing our clinic out in the sticks of Louisiana? Like they were doing a neurology clinic, and people would come in and they were like, "We want soma, we want this." And the guy would just be like, "No, we don't do that."
Yeah.
That's for the
Wrong
clinic."
spot. That
Yeah.
guy's down the street.
Yeah, yeah, but there was a free clinic, and so
Oh.
that's why. And so
Yeah.
you would get these patients like over and over and over, and he's like, "No, we're not doing that."
Yeah, for sure.
Yeah, and so then there's a tenfold risk of overdose when you start taking them both at the same time,
Mm-hmm.
right? And so there's a lot of opioid and benzo related fatalities, and so there's a lot of like co-occurring things going on at the same time.
So what about benzos and other substances?
I mean, alcohol, right? Like
Yeah.
that's the clear one that people are taking it with, and it has a synergistic effect and a lot of like strong respiratory depression. Um, they would take it in the morning, right, to kind of come off of it, but sometimes they would take it at the same time, and then that would cause a respiratory depression. Then you've got the stimulants and the benzos, right, the upper and the downer combination. Sometimes people were using it with like Lyrica or like gabapentin or some other type of sedative thing. Um, I've recently seen like people abusing their gabapentin, which has been interesting to like see.
That's very, 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 very common in institutions.
Okay.
People actually get rich off selling their gabapentin.
Oh, really? Like
Yeah.
in jail?
Yeah, in prison in California, they call them it's Neurontin,
Yeah.
and they call them nanas.
Nanas.
And people are like selling bags of them
Just
for
to get like
a
sedated
quarter for a quarter for a 400.
on.
Like
25 cents?
25 cents for every 400.
Okay.
and so it's a soup for 3.
A soup for
Yeah,
$3?
like a top ramen will get you 3 of them.
What?
Yeah,
What's a top ramen? Like you actually have to give him top ramen?
yeah, that's the currency in there. There's no cash in there.
Okay.
Like there's cash in there, but that's like the drug trade.
Okay. Okay.
But yeah, for like pharmaceuticals and shit like that, people are trading them food.
Okay. Got it.
Yeah.
Okay. Interesting.
Hey, Robert wants to know what are your thoughts on facilities doing Presidex or ketamine to partially sedate along with nalmefene and naloxone to get through acute withdrawal?
For what?
I'm gonna assume
It's for benzos.
it's for no for opiates.
Okay. So the Presidex is interesting, right? Because I've been using Presidex for the kratom withdrawal.
Oh,
And so it's a muscle blockade. And so the whole idea behind that is that you're trying to get them past the restless leg side of it, because with the kratom withdrawal, that's the most intensive side.
okay.
What were the other ones?
Presidex,
So the Presidex like is great, right? Because it's a muscle relaxant and a
yeah.
muscle blockade. It doesn't have any dopaminergic effects to it, right? So you're basically just knocking the patient out.
Okay, so then ketamine is probably the same thing.
Yeah, but I don't know about the ketamine. Like the ketamine is just a this like I wouldn't use the ketamine with the Presidex. Like that basically that knocks them out
For sure.
completely, right? Like I like to keep my patients awake and like alert
Uh,
while I'm withdrawing them. And
so I think this
I let
is
them know like, hey, it's gonna suck,
I
right?
think
Withdrawal sucks.
I think this is the core of what he's asking, right? Is like, what do you think about the sedation, the partial sedation?
Yeah, I'm not for that. I mean, I'm for helping them with their symptoms. I'm not about making it so easy that they are like, oh, this withdrawal was like super easy, right?
Yeah,
I'm
yeah,
like,
yeah,
it's withdrawal, dude. Like
yeah,
it's not gonna be great.
yeah,
And I mainly do it with Suboxone. What's the other one that he has? Naloxone?
yeah. Nalmefene,
I haven't used that one.
nalmefene with naloxone.
I don't know what nalmefene is.
Okay.
So I'd have to research that.
Well, he's next door, so we can ask him later.
Oh, okay. Oh,
Yeah.
okay.
Um, and then the taper queen says that gabapentin and Lyrica withdrawals are similar to benzo withdrawals.
Yeah. In terms of like the GABAergic side of it.
So
So
it's
I've so
painful
I
and
and
shaky.
I think it's dependent upon the person. And so I've had patients that needed a really slow, like drawn out taper from the gabapentin,
Mm-hmm.
and I've written out like 2 month or 3 month tapers where they're on like 1600 milligrams, and I would write out, all right, go from 400 to 300 on this dosing it, right? And I would do 4 times a day, and I'd write out you'd go 300, 400, 400, 400, right? And then in 5 days, go 300, 300, 400, 400. And then in 5 days, go to 300, 300. And
Wow.
I was dropping them down by 100 milligrams every 5 days. But I would write out the taper for them so that they would know what to take at what times.
So that's like more than a 3 month. No, no,
It
no.
was it was a lot. These were like long tapers,
Yeah,
right? And
yeah, yeah.
I'd be like, all right, I'll write it all out. And they were like, what do I take that? And then I would send in, 300 milligrams and then 100 milligrams, and then
400 and like.
it came in like 600 milligrams, 300 milligrams, and 100 milligrams.
Okay.
So I'd send them a whole bunch of like the 100s, and they would come back in, and I would send them a whole bunch more.
Okay.
But they needed this long, slow taper.
Mm-hmm.
Other people just stop it. And so
Yeah.
I'm convinced that it's based upon your genetics and like how your receptors react to certain things.
Mm-hmm.
That some people have no withdrawal whatsoever, but some people have a really, really bad withdrawal. But that's some of the pharmacodynamics of the benzodiazepines are somewhat similar too. And I
Yeah.
suspect the people that have the hardest time with that particular withdrawal are the ones that it binds more tightly to their receptors.
Yeah.
And so they're like, I can't go any like lower, right? I can't go any slower.
Yeah.
But that's why I would recommend the phenobarbital taper, right, in house. Like if they covered it, I think that should be covered by insurance companies, right? Like if you want to come off of a benzo, you should be able to do that in house.
Is that currently
That's not covered.
okay? So how do illicit or designer benzos factor in?
So I think this is what she was talking about, right?
Yeah, the taper queen.
The taper queen, yeah. And so it's all of the, the strong, the high potency, short acting ones that are like sold online, mislabeled as research drugs, but they're very potent, long acting, and unpredictable half lives, right? And so this is where they come into the abuse potential for all of that, right?
Mm.
These are the designer ones that aren't FDA approved for anything, and so they're buying them off of the I don't know, the black market. Like, where do you get those things from?
I mean, I'm sure there's research. There's there's research chemical companies that
Okay,
they're all over the internet.
and you just go and you're like, because
Hmm.
I had some patients that are into that too. Like they would buy a whole bunch of these things online. I'm like, how did you get this? And they're like, oh, I just put it off the internet. And I was like, what? Like,
Yeah. In the early 2000s, around my ecstasy use, I got into research chemicals, and you could
okay,
buy all of this shit online. You know what you could buy online was pounds of dextromethorphan.
dextromethorphan.
It's
The
what the psychoactive ingredient in cough
yeah, cough syrup.
medication.
Yeah,
Yeah.
yeah, okay,
And we would just buy it in a powder form because it's very similar to PCP.
okay.
um, let's see. Uh, the Taper Queen says that have you heard of taking that if you've taken benzos, you are more susceptible to lyrica withdrawal.
If you've taken benzos, you're more susceptible to
I
I
mean, it
think,
makes sense because of your
yeah,
pathways.
it's the pathway. It's the
Hmm.
pregabalin side of it, right?
Hmm.
So I think that's a little bit more addictive. But yes, I have heard of that.
Okay.
They used to think. I remember when I was in I was in residency, right? And this guy came in and he was abusing Lyrica and he was abusing Ambien. And my neurology professor was like, "You can't seize off of that." And I was like, "What? It doesn't make sense. Like, can't you abuse it and seize off of it?" And they're like,
Hmm.
"No, like, there's no possibility." And like, this was like my neurology attending, right? Who was an epilepsy specialist, and he was like, "No, like,
Wow.
that's not a thing." And I was like, "I'm pretty sure that's a thing." And he was like, the guy was like convinced that if he didn't take it, he was gonna like seize. Um,
Well, he was probably right.
yeah, like
Yeah.
it probably seized before.
Okay, so what defines physical dependence versus
Right.
addiction here?
So dependence is like withdrawal and having like when you take a reduced dose, right? Like
Mm-hmm.
that's when you become dependent upon it. Like that's you're physically dependent upon it. And so addiction is when it's compulsive despite the consequences,
Mm-hmm.
right? So there's a behavioral component to it as well, whereas the dependency is just the physical side of it. So not all dependency equals substance use disorder,
Right, but
right?
I think it's a very slippery slope from dependency to addiction for a lot of people. And I know that there's
Right, but
normal people that are dependent.
right, and so then that goes back to like what gets covered for the behavioral health stuff.
Right.
Right? So then the behavioral health side, if you don't have the behavioral component to it, right? They're not going to take you off it because they're like, there's no reason for us to pay $6,000 for you to come in. You can just go ahead and taper it over the course of 5 weeks.
This is another problem with self-reporting
Yeah.
because who is going to self-report problematic behavior around prescription medications?
Right. And so I think that's why there's so many people that are on it for so long that just can't come off of it because it's just not worth it.
Yeah.
Right. Like I tried to, so the person that I knew from Mississippi that came into the diagnostic, she was trying to get a friend that was on the benzo, and I was like, I can't treat them from Texas, right?
Right.
I can't do anything from them, right? Like if you want to bring them into the facility, they're like, no, like we need to find somewhere over there.
Mm.
They went to like 4 different places, and they were like, can you help us? And they were like, no, you don't meet criteria. No, you don't
Yeah.
meet criteria. And so like they were stuck, and so
Hmm.
he was stuck.
Okay, so what does benzodiazepine withdrawal look like clinically?
Okay, so it's like sort of like the same thing as like alcohol withdrawal, anxiety, insomnia, a lot of autonomic hyperactivity, high blood pressure, tachycardia, tremors, perceptual changes. What else is there? Sensory hypersensitivity, like you kind of like see things, seizure, delirium, and psychosis in like really severe cases. So it necessitates a withdrawal in the hospital if you're abusing it.
So, let's see, what is his name again? I think it's Kent. Yeah, Kent. Kent, we just recently had a live episode about 7 and ketamine, but he just said he hasn't tried it, but it's supposed to be 13 to 30 times stronger than morphine.
What
Um,
what is?
Ketamine. Not ketamine. Kratom and its derivatives, 7-0.
So what do you mean by 7 times or 70 times?
13 to 30 times stronger than morphine. We talked about this.
Yeah, but it like in terms of like the affinity to the receptor or in terms of like the withdrawal stuff.
So, uh, that is a good question of what he is talking about. What are you talking about here, Kent? Um,
Because
Tinnitus, skin sensitivity, depersonalization are also
yeah,
side effects.
yep.
Okay.
That was from the Taper Queen.
Yeah.
How long? I wonder how long she's been on it, or like what she's how she's coming off of it. Oh no, she's on the methadone now.
Yeah, and now she's coming off of
She's
it.
coming off
Matter of
the
fact,
methadone.
Taper Queen, find me on Instagram or Facebook and message us. We'd like to talk to you.
Okay.
Let's see. So, what makes benzo withdrawal uniquely dangerous?
Right. It's the seizure risk, right?
Mm-hmm.
Even at therapeutic doses, there's a likelihood of having a seizure when you come off of it or stop it abruptly, especially with like long-term use.
Mm-hmm.
The long-term dependency on it becomes largely psychological in terms of like you've been in this constant withdrawal cycle, right? So it's like I need this for my anxiety. If I don't take this, I'm going to get anxiety. When it's really the drug that's causing the anxiety,
Yeah.
which is like so insidious, right? And so there's a cross tolerance that occurs with the barbiturates and all these complications that occur from it. And so we kind of talked about the withdrawal um, stuff and like how you would go about doing it.
Yeah, but how do you assess the withdrawal risk?
So I usually look at the duration in which the person's using, the amount that they're using, and then how much alcohol they're drinking at the same time.
What if they're not using alcohol?
Then just look at the duration of it, but I still put them on. I put them on the taper. Right?
Yeah.
I'm gonna do the taper anyways because what happens with the phenobarbital taper is that I overshoot what it is that they actually need, so
Mm-hmm.
that the first like day or so they're like sedated, and then I bring them down nice and slowly off of that.
Okay.
So there's really it doesn't hurt that I overshoot it because I'm trying to figure out where their dependency need is to like match it and then start coming down from there.
Okay.
Yeah.
When is inpatient management
So
indicated?
higher doses and like the more potent ones, right? Like
Okay.
the how much Xanax are you taking? Because that's usually the ones that they're abusing. The people that come into the
Yeah.
treatment facility, they're not really abusing the clonazepam as much.
Well, so Valium is a pretty
Yeah.
Valium, but I think it's also because of what's being prescribed. Valium is very easy to get prescribed.
On the streets or like in clinic.
Yeah.
Okay.
And then Xanax is so readily available on the streets. I don't know how many, like, what percentage of people are coming in because of benzos are coming in because of a prescribed benzo, or how many of them are coming in because they're getting it off the streets.
Right.
I would say a lot of them are probably getting it off the streets,
Yeah.
which is interesting too because it's such a small amount of benzo nowadays. You get mostly other shit.
That's inside of it.
Mm-hmm.
Yeah. I don't think the benzos that are out on the streets right now are actually benzos.
Yeah. No, in my opinion, right, it hasn't been like that for a long time. When I started using benzos off the streets, I would go to Mexico and get them,
Mm-hmm.
and I watched as it changed. And like I said, I used it for time traveling purposes,
Right.
and eventually it was just pass out purposes.
Right.
As that change happened, and really all what it turned into was just pressed fentanyl.
Yeah, and that's what I'm seeing today, right?
Mhm.
If someone comes in and they're like, I'm on a bunch of benzos, right? I'm like, we test for fentanyl.
Mm-hmm.
So that's one of the things. So we're definitely getting the cups,
We
the
have
20,
them.
the 24 panel cups.
Mhm.
Okay, that does kratom, that does the
We haven't pulled the trigger on the kratoms yet, but we do test for fentanyl currently.
okay, yeah,
And it's important because we also send stuff into a lab. If there's a relapse event or if somebody's coming in and it's testing for whatever, we're sending it in because I want to see what levels are actually there. Because a lot of
if they're
people are
going down or not.
not just that, but they're ignorantly taking fentanyl. A lot of people are.
Yeah.
It's in coke, it's in meth,
yeah,
it's in benzos, it's in everything.
yeah.
And so my whole fear around this is you're taking medications or you're taking drugs. First of all, you don't know what's in it. And so it's a shock for clients when they're like, what do you mean I tested for fentanyl? It's like, yeah, It's
Yeah,
in
it's in
everything.
everything. Yeah,
Yeah.
yeah, yeah. Is that a wake up call for them, or are they just like still?
I think most people just kind of assume it. When they hear it, it's just kind of like a confirmation of something that they've already
Hmm.
thought.
Yeah,
Because think about it, like
you're like this doesn't feel like meth,
for sure.
or
Well,
like
that was the funny
this
thing.
doesn't feel like cocaine at all, right? And I'm like,
About
that's
5 years
probably not.
ago, 5 years ago, there was people started calling it sleepy dope, and it's like meth does
What?
not put you to sleep. Yeah,
Sleepy dope.
yeah,
Yeah, no, that's fentanyl.
yeah.
Well, the way that I can tell is when they come into the hospital and I'm like, tell me what your withdrawal symptoms are. And they're like, oh, I'm taking a lot of meth, and then like I got diarrhea and abdominal cramping, and I'm just like, that's not meth.
Yeah,
They're like, what do you mean? And I'm like, oh, that sounds like fentanyl, not meth.
yeah.
Yeah.
And it's funny. It isn't funny, but like 5, 6 years ago, when this started becoming a thing and they started putting it in everything, we were
Oh,
spending a ton of time in TJ, and we were asking them like, why is it in everything? And they put it in everything so that you build a physical dependence on it, that you need it. Right?
yeah, and
Meth
you have
isn't.
to go back to it.
Hmm.
Yeah.
Meth is not a physically dependent
Nope.
thing.
You just stop it and it goes away.
Coke isn't. But
Yep.
if you have this chemical hook that is physically dependence building, now
That's so
it's just
crazy.
impossible to get off of.
So then that's how they get you to keep coming back to
Hmm.
it over and over and over again.
Hmm.
Yeah, that's crazy.
Yep. So how does an inpatient taper often proceed?
Okay, so
Like,
I don't like doing inpatient tapers,
okay.
um, mainly because they take too long to do, and I'm using phenobarbital for that,
Hmm.
right? So I'm not usually tapering them with the same medication. Like I don't like to take a person off of a benzo with a benzo.
For sure.
Like that just doesn't make sense. That doesn't make sense to me,
Yeah.
right? And they do it all the time, or like they'll be like, "Oh, I'm going to take you off of Ativan," or like, "I'm gonna take you off of Xanax with diazepam," and I'm like, "What?" Like it's so much easier to take them off of it with phenobarbital than it is to do
What is the thought process?
on what?
Benzo with a benzo.
I think that's people that aren't classically trained in addiction medicine are like do that route because what they're trying to do is like convert it over to a longer acting one and then see how that goes. Like and
Oh,
they don't usually use phenobarbital. Like nobody's sending you home on phenobarbital.
for sure.
And the reason they're not doing that is because of the risk of someone
So
dying off of
dangerous.
it. Yeah. So like if I I've given people prescriptions for phenobarbital like in very rare situations to take home. If you're married and you've got a spouse and your spouse is the one that's holding on to it, then I've got a therapist and they're like I'll have Amy call every day,
Hmm.
right, to make sure that you're not drinking on it or you're not abusing it. Like I have to feel very safe that you're not going to hurt yourself on the phenobarbital. So a lot of doctors don't do that at all. So they're more accustomed to doing the benzodiazepine taper.
Yeah.
But the phenobarbital taper is the most effective one in
Yeah.
terms of an inpatient setting, and I can usually do that in like 4 or 5 days.
Oh, that's not bad.
Nope, not bad at all. I mean, as opposed to like being miserable,
Weeks?
yeah,
Yeah.
like do it. But it that goes back to the cost, right? Like the cost for that is 5 grand, right? Like let's call it 5 grand in an inpatient setting, right?
Okay.
Or like you come into a detox and I detox you off of the clonazepam, 5 weeks. I'm sorry, 5 days,
5 days.
right? 5 grand,
Okay.
right? Versus like, oh, we can't pay for that. Do it in an outpatient setting, like zero cost to them,
Yeah.
right? Or $100 cost to them. But like the possibility of them actually coming off of it is it's so
Not gonna
variable.
happen. Yeah.
Yeah.
So what non-pharmacological supports are essential during the tapering process?
Okay. Well, wait. Say that one more time.
What non-pharmacological supports are essential for during the tapering process?
Okay. So then it's like it's sleep hygiene, doing better with like are you in a relapse pattern? It's a lot of psychoeducation, a lot of sleep hygiene, structured daily routines are all like helpful. I mean, it's just getting into recovery.
So basically, like the workout, eat better.
Right. Work
Okay.
out, eat better, and do all of those things.
Okay.
Yeah.
Which benzos are most used for anxiety?
Yeah. I mean, so I'm alprazolam, like that's the best use case for that.
Yeah.
Lorazepam is reliable, but it has like a shorter like half life, or like I'm sorry, an intermediate half life for all of that. Sometimes clonazepam for panic disorders, but I don't love doing that, right? Like I don't. We used to use clonazepam at the neurology clinic, but then when I got into addiction, like we just like that's a no go for me now.
Yeah. It's always interesting to me when you look at like pharmacological effects of chemicals and how typically something that has the ability to cause the same symptoms is often the cure for the symptom. Antidepressants, anti-anxiety meds, like
Mm-hmm.
all of these things, especially if you don't have it. If I don't have anxiety and I start abusing benzos, I immediately have skyrocketed my anxiety.
Because you're in withdrawal.
Yeah,
That's all like withdrawal related. Yeah.
crazy.
And so when we talk about epilepsy, right, we use diazepam for that
Hmm.
mainly, or lorazepam, and then clonazepam. Yeah.
So which benzos are primarily hypnotic?
So we look at that for sleep, right?
Yeah.
We use temazepam a lot for sleep, and then the long-acting flurazepam. And so like those are the use cases for like those two, right? Temazepam's like, been used a lot for sleep.
Okay.
Yeah.
So which benzos are procedural or ICU mainstays?
So those are the really really short-acting ones,
Okay.
right? The ones that like rapid onset can like knock you out almost immediately, and then when you're done, then you come back, and so it's done. It's out of your system,
Okay. Um, let's see. How are benzos scheduled federally in the U.S.?
right? So there's Schedule 4
Oh,
controlled substance because
okay.
there's a medical use for it, right?
Yeah.
There's you can actually do something with it, but they're trying to consider it to be a Schedule 3 because there's abuse potential
Massive
too.
abuse.
Yeah, but
So
because
funny.
because there's so many people out there using it, they're not going to do that because
Yeah.
it then bumps it up to a different category, different
Hmm.
zone, right? And so then this goes back to there's a lot of like requirements and a lot of like shifting laws that are occurring in terms of like how you're supposed to monitor a patient that's on a controlled substance like that. So like they're more and more like at the PDMP searches.
4. That is so crazy.
Yeah. Do you know what a PDMP search is?
Uh, no.
The PDMP search is that every state has a registry of all their controlled
Oh yeah.
substances. So if you go pick it up from a pharmacy, it gets linked to your name.
Right. Right.
So I can run a report that says, here are all of the prescriptions you've gotten in the
Yeah.
last 3 years. And how many different doctors have you got it from? How many like how
Wow.
often are you getting it? What are you getting in combination of, right?
Hmm.
So that one's really useful to have when they are coming in to treatment and you're like what do you want? And they like completely lie to you
For sure.
about all of that stuff.
So what's changing with the telemedicine and
Okay.
benzos?
So the DEA is formalizing special telemedicine registrations so that you can't just go in and be like, "Oh, I'm like sure, like here's a benzo. You get a
Yeah.
benzo, you get a benzo, you get a
Yeah.
benzo," right? Especially like after COVID, a lot of clinics went to like online, and so like there
Yeah.
isn't as much drug testing going on with that. And so only schedules 3 and 4 can be prescribed via telemedicine, right? And it requires a special documentation, a special license. They're basically cracking down on abuse,
Hmm.
right? By getting like they're making the doctors go and do all of these searches so that you're not getting your opiates from one doctor and your benzos from another doctor and your Adderall from another doctor.
Yeah. I
So
think a lot of that changed with the opiate crisis, right?
yeah,
Okay.
so like all these concerns around diversion and what that looks like for them.
Okay. So how are designer benzos being regulated?
So this goes back to the Tabor Queen's questions, right? So
Yeah.
they're all Schedule 1. There's no medical
Oh,
there's
really?
no medical
Okay.
there's no medical benefit to it. There's no medical reason to have it because there's just a high abuse potential.
Yeah.
Right? So once you hit that particular thing, it's like there's no reason to have it.
Okay. So what other policy levers affect benzo use?
So it's the PDMPs,
Okay.
right? So like the PDMPs are basically what they're using as their stopgap. And I guess that works better in the northern states and the ones people that aren't buying it off the street.
Yeah.
But then doesn't that just force them to buy it off the street?
I mean, so you know what's crazy too is the from my point of view and like from what I've seen on the streets was that the more restrictive laws are in any given state or county,
Mm-hmm.
it just costs more. But the abuse is just as problematic,
Right.
right? So you like talk about like the northern, like especially along the Canadian border.
Uh huh.
You're talking about like the Washington, Oregon, Michigan, like all of the like they have massive problems with abuse, and they're not just walking across the border and getting like Baltimore and New York and like all these
Yeah,
places are
yeah,
so
yeah.
fucking far from Mexico,
Yep.
and the addiction is just as rampant. The difference that I've seen is just how expensive it is,
Oh,
and
because it costs more to get up there.
hmm
Okay. But that's one of the ways that they are cutting back on the abuse, right? Is that insurance companies aren't covering it anymore.
hmm
So they're going back and being like, oh, like you've been on it for 3 years, right? Like you don't need to be on it for 3 years. Like we're not covering that anymore. They're actually following some of the guidelines, not completely because the doctor can always override that or like get a clearance for it.
hmm
But there's black box warnings on opiate and benzo combinations. Like
yeah,
you shouldn't really do that. And so when you go into the pharmacy, they're like, hey,
they call the
yeah,
doctor.
and they're like, this person's on this or this person's on that,
Yeah,
right? So that you're aware that they're on both, and then you have to like call in and say, okay, I'm aware that they are using both of those at the same time.
yeah.
So that just puts another barrier to it.
Okay. Um, so why is long-term benzo use? Oh wait,
Yeah, so controversial,
yeah.
right?
Why?
Because it was never approved for that, right? So
Yeah,
this
yeah,
goes
yeah.
back to what the Tabor Queen was talking about. Two
Yeah.
weeks. I didn't think it was that short, right? I thought it was. I know it was. I thought it was like 6 to 8 weeks, but it was never FDA approved for anything longer than that.
I mean, different drugs are probably have different guidelines, but I could totally understand why it was 2 weeks for Xanax.
Yeah. So
Xanax is such a powerful drug.
I've never had that before. So like you just get like it's like really addictive.
Yeah, it's very euphoric too.
Okay.
So it's probably like a lot of dopamine connection there. But
Mm-hmm.
um, I always used it in conjunction with opiates, and it just like takes it to another level.
Got it.
But like I said, I time traveled with it mostly. So
Time travel. It's such a unique way of putting it.
I mean, how else
Yeah.
do you put it? I woke up one day,
I blacked out for a while.
dude. I woke up one day. Um, I came to, and I'm driving, and I've got four people in my car, and I'm like, where are we? And they're like, we just crossed the Utah border, and it's like 10:30 at night. It's snowing,
Right.
and I convinced everybody to like take work off, and we're gonna go snowboarding. And I like pulled over and had to like have everybody explain to me how this went. And they were like, they didn't believe me at first that I didn't know what
Yeah,
was going on. And then I
yeah.
had to explain to them, like, dude, never let me convince you to do anything again, because
Yeah.
I have no clue how this happened. Yeah,
And so
and I'm driving.
I know
Like,
that's the scary part,
yeah.
right? Yeah.
So, what's the debate around benzos and dementia?
Okay, so there's observational links between the two, and they
Mhm.
suggest that there's an increased risk of dementia
Mm-hmm.
for patients that are taking benzos for long terms, right? It's it's not actually like it's not correlated because there's other confounding variables like in terms of anxiety, insomnia, and other things that are going on. So there's no proof of it, but they're looking at it as like a potential for like long-term dementia risks.
Okay, so like kind of anecdotally, right? There was like a whole generation of people that were getting massive amounts of benzos prescribed to them,
Okay.
and they also that whole generation has gotten Alzheimer's in like record numbers. And one of the things that I also heard around this was it was the rise of asbestos in buildings
Right.
back in the day. So like all these things kind of lined up, but
But then they're also like the advances of sugar, like Alzheimer's is
yeah.
like diabetes type 3.
Well, what I've seen, like what I've noticed and what I've heard from like other people, and just kind of like throughout my life of abusing drugs and like knowing people that have gone through stuff or whatever, is that um, we've always been able to know of somebody that had Alzheimer's and then kind of track it back to like they abused benzos like no other.
Hmm. Okay.
hmm And so, like I said, no study done around that,
Right,
no
right, right.
nothing like that. But like
Anecdotally.
anecdotally,
Right,
like
right,
we've always kind of made that assumption and connection that like, oh yeah, they must have
right.
abused a lot of benzos, and a
I
lot of
mean,
them
but
have.
you never know, right? With like people. Like grandpa's not really gonna tell me like what his abuse cycle was back in the
No,
day.
but their kids know. Like a lot of it was this. It was like the grandparents. Like what it was I knew a bunch of people whose grandparents had Alzheimer's,
Okay.
and they would tell stories, or their parents would tell stories about like how they got started on benzos, and it was
Okay.
all from that
Got it.
generation.
Got it. Got it. Got it. Got it. Got it. Okay.
So smoking affects how medication is metabolized in the liver. That's what Kent said. Um, okay, so how do patient advocacy groups view benzos?
I mean, it's tough, right? Because like we're on the side of like, oh, you shouldn't take it. It's
For
like not
sure.
good at all, right? But then there's also groups that are like, hey, like you need to have this for X, Y, and Z reason, and there is a clinical use. And there's all these advocacy groups that are like, you can't just take these patients off of it, like they need it.
Yeah.
So there's a lot of criticism around like rapidly detoxing patients. Like a lot of clinicians are like, you'll be fine. Let's just stop it, right? And not
Mm-hmm.
really going into the compassionate side of like how bad is your withdrawal actually. And so they are pushing for more like slower tapers and allowing for patients to like come off of it like at their discretion, but more like work around that. I would love to see more and more patients that want to come off of it. And if you like demonstrate that you want to come off of it, you've been on it for a long time, that the insurance company starts covering your detox side of it.
Yeah.
But I think what we should start doing is like we should market towards that to be
Mm-hmm.
like, hey, do you want to come off of your benzos?
That's a good idea.
Right? Then like let's like we'll come in and it'll be this much. Right? But we're gonna put you into an IOP program specifically for patients that
Yeah.
don't identify as addicts but could benefit from
That's a really good
this.
idea.
I know.
Yeah.
that was like my business model.
Really?
Yeah, because
So
like
that's what Aftercare Doctors was kind of
no, no,
doing.
no. That was like 3 businesses ago, right?
Oh.
One of them was like, I could take people off of benzos, and
Yeah.
it would be you would get them into a group or an IOP
Like a support type group
right?
with programming.
Specifically, yeah, with programming specifically for benzodiazepines, right? So what you would do is you would detox them off of the benzo,
Yeah.
right? And then you would be like, okay, like in order for you to come into the program, we're not just going to detox you, we're going to detox you
And you have to
and,
commit
and you have to
to.
commit to this like 5 week program where it's like a 5 week online IOP because you can do IOPs online now.
Yeah.
You have 5 week IOP, right? But it was geared towards people that could use better skills around life
For
that
sure.
weren't related to benzos, right? And then, but you wouldn't talk about the addict and the alcoholic and all that stuff. You'd
Mm-hmm.
just be like, here's some life skills for you. Here's what you should take a look at, and then have like a long term support group around that.
That makes sense.
Yeah, I think it'd be a great business model.
I think so too. Did you start that business?
That's the pandemic hit.
Uh,
So that was the idea. Like the clinic was going to be called the 417 clinic. After the big book acceptance is the answer, it was on page
Mhm.
417, I think. And then that didn't go anywhere because then the pandemic hit, and I was like, oh, like look at all these people relapsing.
it's
And
actually a
then,
really good idea. Okay.
yeah,
What about the benzophobia in addiction care, which is
right. So it's like we're not going to prescribe benzos ever or
Yeah.
at all, right? There's no need for it. You don't need to be on it. Like take you off of it. And some people like that's their little pacifier, right? Like,
Mhm.
well, I will take patients in the hospital off of the opiates. And I'll be like, look, I'm not going to give you opiates and benzos at the same time. Like,
Mhm.
if you want to take it when you get home, like that's fine, right? Or they'll come in and they're drinking and on an opiate or on a benzo, and I'll be like, look, I mean, you really shouldn't be on both of them, but like, I'm not going to take you. I'm going to take you off of both of them while you're here, but it's your choice if you're going to start it up or not.
Mhm.
And then if they do, they do. If they don't, they don't, right? But like, that's the hospital setting. And it's usually older people,
Yeah.
like in their 60s or 70s,
So how do benzos fit into current overdose trends?
right? So we talked about that, right? Like it's overall, it's been on the decline because of all the PDMP things that we have out there.
Right.
But they are still pretty heavily implicated in a lot of the fatalities that are out there.
Yeah.
But it's always a combination of the two.
Yeah. So
Yeah.
what harm reduction messages are essential regarding benzos?
Uh, avoid using it with alcohol,
sure.
right? Avoid using it with opiates, right? Avoid doubling up after you miss a pill. Like, never do that.
Yeah.
Like, you don't, if you missed one, you missed one, right? There's no need to like take it again. Sometimes carry naloxone when you're taking both of them at the same time, just in case there's like a risk of overdose. and just the risks of what does long-term use look like before they actually start and they get hooked on it.
It's so crazy that that is not. There's no like educational requirement around these medications before you get them prescribed, but you have to take a driver's test.
Yeah.
It's like way more likely to die abusing benzos than, I mean, maybe not, but
No. A car accident? No way. 10,000? What do you think the death rates for car accidents are?
okay, this is really what I'm saying is like if you go down that road of abuse
Okay, yeah,
where
yeah,
you're taking pills off the streets
yeah. Okay.
is really what I'm trying to say.
Yeah. Yep. Yep.
Because now you're opening yourself up to exposure to a lot of other harmful things than
Yeah.
just the benzos. How can prescribers practice safer benzo prescribing?
Like that's like harm reduction, right? There's always ways to like give non pharmacological ways of like dealing with anxiety. Like,
Mm-hmm.
where's the you always talk about where's the T? Where's the T in Matt, right? So
Mm-hmm.
like where's the T in all of this? Like instead of just prescribing someone Xanax or something, like are you giving them any cognitive behavioral things? Is there a limited time in which you're giving them the benzos? Is it only for X amount of time, not for this full duration? Um, and
You know
then
what's interesting? I have the same I have the same feelings about benzos and SSRIs around like how people are misprescribing them, but I feel like you have a different um, like a different thought on both of them. That like there is still long-term SSRI use that's okay versus this is probably not okay.
I I think that to the model that we're currently doing,
Mm-hmm.
the SSRIs don't fit into that model, but we're also using a population of addicts and alcoholics,
For sure.
right? The ones that are like highly traumatized. So, like in my particular practice, not so much,
Mm-hmm.
but it could be beneficial in a population that's not addicted or not alcoholics and addicts, right? Like, why would I put someone on a mood stabilizer when they can get the same benefits from like Lexapro? Right? Because a mood stabilizer, like I need for them to be monitored and all of those things.
Mm-hmm.
So I mean, maybe for the general population, like that's okay. Like my practice is specifically
For
focused on
addicts.
addicts and alcoholics. So like the idea is, I mean, as the book comes out, right? I'm writing a chapter on, like the next steps, right? And I think one of the biggest things that I want to see in the next steps is like advocacy for making addicts and alcoholics a separate population group that you treat that they don't have anxiety and depression, they have something else going on, right? And so to look for those particular things.
Megan said the first time she overdosed, it was because of benzos.
Hmm.
Actually, it was a really crazy situation.
You're giving her mouth to mouth at this point?
This was the time where I called the ambulance.
Okay.
It was the only time that I called the ambulance, and we like whatever we got high, and we're like standing in an elevator, and I saw her like passing out, standing up,
Okay.
and I was like, oh my gosh, and I like caught her, drug her out to the street, and like had somebody call the ambulance or whatever. But it was,
It was a Xanax overdose.
and all she took was point 0.5 of Xanax, and it
Interesting.
caused an overdose like immediately.
Yeah.
The Taper Queen wants to know: do methadone doctors have to get an extra certification like Suboxone doctors? And if so, why are they so unfamiliar with things like benzo withdrawal?
I think so. Yes, they do have to get extra certification. I think that there is. I think there's a class on it. I think it's like it's not a long class, like an 8-hour class. It's like it's not that much at all,
Wow.
right? In order to be a methadone prescriber, I almost started. I almost
Eight
went.
hours.
Yeah, I mean that's the box on class is 8 hours too.
Wow.
Yeah, that's it. Um,
That is so crazy.
but I mean, I had a fellowship in addiction medicine for 2 years, right? So I
Yeah.
was like, okay, like I
Tell
definitely
them
qualify for that.
how much addiction medicine training like just the average MD gets throughout medical school.
Like maybe one like lecture or two lectures
So like
tops,
hours. How many hours?
like one or two.
One or two
Yeah, I mean,
in
like
how
there's
many years of school?
it like 4 years of school, right? But you do your psych rotation, so maybe you get a little bit more in your psych rotation, but like
So crazy.
your first 2 years, like not that much at all.
That
And
is
they're
so
really
crazy.
hoping that you get it in your psych rotation. But then if you're going into like surgery, they're like, why do you need to worry about alcoholism, right? Like
Yeah.
you're probably going to be an alcoholic, so it's like fine, right? Like,
So funny.
no, like you don't get very much education on that at all, or any
That is so
training on
weird.
that.
Isn't
I
that weird?
I also think it's like it's gonna sound terrible, right? But I think it's a lot of foreign grads that go into like psychiatry and that go into like family medicine practices because they're underrepresented and underserved. That when they come in, they're just like they're happy to prescribe whatever it is that you want to prescribe,
Mm,
right? So there isn't like very much training out there on those particular things.
okay.
Um, so going back to the ways to make it safer, right, is to do the PDMP searches to
Hmm.
find the lowest effective dose possible. Um, yeah, and so it's just to be more mindful around the whole thing.
Okay, so what's unique about benzos and the SUD populations?
It's usually started for a legitimate purpose, right, for initial symptoms, but then it slowly, quietly goes to abuse, right, and it insidiously just starts getting higher and higher doses, and they start drinking with it. And so they're like, oh, I still have anxiety when their anxiety is not really anxiety, it's just withdrawal when you're in
Mm-hmm.
withdrawal all the time. And because of the high amounts of shame and the fact that like prescribers are open to going to higher and higher doses, that it's just like, oh, like we're how to get to 2 milligrams, right? How,
Mm-hmm.
2 milligrams twice a day? How to get to that, right? And
Yeah.
it's just like, okay, like we'll just go up on it, right? You're still having anxiety? We should just go up on it. I'm sorry, it just happens a lot with benzos.
I mean, yeah, because a lot of prescriptions go up in point 0.5, right?
Yeah.
Okay.
Yeah. And so, but the thing is, like, do you really need 0.5? Does it need to go up to one? Do you need to go up to 1 milligrams? Can you get the same dosing by like a half of it? Or like, do they even prescribe half of it?
Um, a while back, the taper queen said that 2 milligrams of Xanax isn't even psychologically. I mean, what did she say?
Psychologically effective?
Mm-hmm. She said something like that.
2 milligrams is a lot. I mean,
Like,
but it's like it doesn't cause withdrawal. Or physiologically addictive. Maybe that's what she said.
I gotta find it. It's back here somewhere.
Okay.
We've had a really active chat today. This is really cool.
Awesome. You did all the legwork of
Getting
posting in all the
people in
groups.
there.
Yeah.
Yeah. Um,
How many people were in the chat today?
so probably 5 or 6 active chatters.
That's
We've had like,
awesome.
yeah. But I mean, we've probably had,
Your engagement's through the roof today.
yeah.
Yeah.
Yeah, yeah.
You get engagement points for every time someone texts?
So yeah,
Okay.
yeah, you get like those. I don't really know how it works yet. Um, but yeah, every time somebody chats, there you get some kind of point. Um, whoever's in here that has not subscribed, please remember to subscribe. Okay, so how should we talk about benzos to our patients?
So wrapping it up, right? Like
Mhm.
kind of like basically normalize dependency as pharmacological, not like a moral issue. Right? So it's like it's okay, like, it's you're not a bad person. Like let's talk about tapering down off of this. But then explain to them the withdrawal risk before you even start them.
Yeah.
Right? To be like, hey, this is highly dependent. This can cause dependency. And I've seen so many patients to be like, oh yeah, they just prescribed it to me, and then they just started going up on it, right, without even considering what the long term effects of it are. And then is to watch out for the long term effects of it. And in terms of like, how am I using it to like maybe deal with my trauma? Are there like attachment issues going on? How attached to this medication am I? Am I willing to let it go?
Okay. So how do we handle benzodiazepines with bupe or methadone
I don't prescribe the two
together?
together because of there's such a high risk of
Adverse
overdose
effects.
and
Yeah.
adverse effects from it, right? So that's a no go for me. And so it's tough when they're taking both of them because it means that someone didn't check the PDMP,
Hmm.
right? If they're being prescribed it or they're taking it illegally and they're not drug testing them.
Which would be crazy.
Yeah.
It.
But it happens, right? Like
Yeah.
you get into it for like they're not testing you every week.
Yeah.
Like when you go into a methadone clinic, like what's it like once a month, random?
Yeah, but benzos are so long acting. It stays in your urine for so long.
Right.
So, yeah.
Yeah.
Okay, so what research questions around benzos still need answering?
So there's like in terms of like the efficacy and the use and things like that,
Mm,
and what and why they're using it and what the best medications for it are and what the best uses for those are. So I
Okay,
jumped ahead in terms of like the questions.
that's fine.
Yeah, so this is the last one.
Okay, so what should listeners take away from this episode around benzos?
So it's a double-edged sword, right? In terms of like what is effective, what's useful, what's not useful, because there's some like really good useful reasons to have someone on a benzo, but then there's also like problematic reasons to have someone on a benzo, and we don't really explain to them the risks that they're on before they actually take it. So it's to ask your physician a lot of questions as to like, hey, how long are we going to be on this for, right? Why are we taking this, right? As opposed to like, I just want the relief. And so having those tough conversations before we actually start, um, and then just being as compassionate and evidence based as we possibly can be in terms of like giving them the relief that they want,
Mm-hmm.
but also trying our best not to form a dependency on it.
Yeah.
I think that's the biggest thing, right? Is just like balancing both. Because I think most doctors want to be helpful. They don't want to harm the patient, right? But they think that if they just give them what they need or what they're asking for, like that would be beneficial for them long term. I don't see.
It's interesting to me to hear, like, as we have these conversations, some of
Mm-hmm.
the realizations that I'm having around, these are some of the most educated people in the country, right? They're
Yeah.
also some of the most highly regarded people in the country as well. um, and it's just very eye-opening to hear stuff around this, because it's like they don't actually really know around what I go through around addiction and all that
Yeah.
stuff. It's like,
No.
they don't really know what's going on. And
That's why it's an interesting field to be in, right? And it's so cool when somebody that has an addiction goes into this line of work,
mhm,
because you're like, come on, like you're not gonna get bullshitted by people,
for
right? You're
sure.
like, what's going on, you know how to help, what's actually gonna get through to these people. So like that's the gift,
Yeah.
right? Of actually like coming through the entire process.
Okay.
So, okay, awesome. 2 weeks marijuana
Marijuana.
and CBD and all that stuff.
Okay, guys. So thank everybody for coming and hanging out with us. A lot of you guys were here for the whole time, and I really appreciate that.
Okay.
So our next live together will be 2 weeks,
Yep.
and it's going to be on marijuana. And I think I'm going to have a live in between now and then. So just look for the thumbnails in the post. But thank everybody for coming. And we're out.
Okay.